частью этой конференции. Я, конечно, не говорю по-украински, но я разумею. И я выросла в Кишиневе и уехала в Америку много-много лет тому назад. И, конечно, когда тут это у вас все началось, очень хотелось что-то сделать, чтобы помочь. Now I will speak to English because I actually don't know any terminology in Russian. I got my education in the United States. How do I change slides? Okay. All right. The goal of this presentation today is to discuss the rationale of total neoadjuvant therapy for rectal cancer. And by the way, the titles are Google Translate, so if they look stupid, I apologize. Since I don't speak Ukrainian. So thinking about the historical rates of local recurrence in rectal cancer surgery, they were incredibly high. So all comers undergoing surgery for rectal cancer would recur at rates of 26%, but by the time you had a stage 3 rectal cancer, the recurrence rates would go up to as high as 46%, which is obviously not acceptable. And that is why the effort for a long time was on trying to figure out methods of decreasing the local recurrence in the patients undergoing treatment for rectal cancer. Well, how do we decrease local recurrence? Well, first and foremost, the most important step is good surgery, and we all know that that involves total mesorectal excision. I don't need to tell this audience, but it's still, I think, useful to retrospect about what was happening before total mesorectal excision, which, by the way, was described in 1978. But it took almost 20 years for it to be accepted. Why? Because it was described by one surgeon in an isolated hospital in England. And when he reported his outcome of 4% recurrence rate after rectal cancer surgery using TME, nobody believed him. So he writes his paper. The paper is published in a major journal. Nobody believes him. And they sent this auditor from Canada to go back, look at every case file, redocument the recurrences, check the CT scans and the MRIs and the documentation on each patient, and then rewrite Dr. Hill's paper. So this paper that I'm quoting here by McFarlane et al., that's a rewrite of the original total mesorectal excision paper confirming the 4% recurrence rate. And that is the time when finally this technique takes over and becomes the standard of care. And again, that was because the recurrence rate for R0 resection was an acceptable 4%. What else happened at the beginning of our century in terms of improving outcomes for rectal cancer locally? Well, obviously, it's the whole movement towards administering preoperative radiotherapy, and that is the study that everybody quotes, and I'm sure you're very well familiar with it, which randomized patients to undergoing radiotherapy before surgery as opposed to after surgery, and then administering the chemotherapy postoperatively. And what they showed is that you can nearly half the recurrence rate with the administration of chemoradiation before surgery, while having no changes in survival. And that is because the administration of chemotherapy with radiation after surgery was better tolerated, and more patients were able to successfully complete their treatment. But please note that these studies all showed equivalent survival. So yes, we have been improving local control with these methods, but there has been no improvement in survival, both disease-free survival and as far as overall survival. And so that alone was sufficient to make the preoperative chemotherapy and radiation a standard of care, but much more needed to be done. So while research is going on, what is the standard of care? The standard of care is staging of the rectal cancer patient with endoscopy, pathological assessment, CT chests of an abdomen for metastatic spread, CA, and then some preoperative staging like an MRI or endoscopic ultrasound, so that the early stage tumors can undergo low anterior resection or local excision in isolated cases, And then obviously the highest stage tumors undergo preoperative treatment. I'd like to point out to you that what I'm putting up here is the NCCN guidelines from March of this year. And the reason I'm pointing this out is because there's been a very big change in the NCCN guidelines in this last incarnation around the concept of TNT, which is why we're talking about it today, and I'll get to it. But all of that is in the context of good surgery, which I cannot stress enough. These developments led to the ability for us to also abandon the need for abdominal perineal excisions. And what I'm showing here is what's happening in the OR and the other space, which is that with preoperative chemotherapy and radiation and good technique, surgical technique, you can offer sphincter-sparing preservation to patients even at the ultra-low level. And we don't have to watch all of this. The point is that you can cut right above the elevators, and then sometimes even sacrifice a half or even the whole internal sphincter if you have to, and still perform a colorectal anastomosis in these patients while offering a curative intent operation. We don't have to watch this video. I just had it up because it's a nice one. So you can have it later if you want. So what happens? Okay, let's go. So local control, sphincter preservation, all of that improves with administration of chemotherapy and radiation to shrink the tumor and with good surgery. But what hasn't improved, and we're now 20 years later, is overall survival. So if you look at the data from 20 years ago, the survival in patients with high-stage rectal cancer was about 70%. And the more recent studies, it's the same frustrating rate. And none of these studies are showing disease-free survival improvements or overall survival improvements. Why? What do we do about it? Well, initially, the idea was maybe we can do better by then offering adjuvant chemotherapy after surgery. But 4 adjuvant chemotherapy trials, unfortunately, disproved that concept. So multiple studies were trying to suggest, we were trying to prove that administration of chemotherapy after chemotherapy radiation followed by surgery improves survival, yet they are not able to show it. And I'm just going to quickly indicate to you this data. So EORTC 22921 randomizes over 1,000 patients and is unable to show a benefit of chemotherapy after rectal cancer surgery in patients with high-grade tumors. There is no benefit at 10 years either. And that's a big, big cohort. How about, why is this misbehaving? Okay. And so the conclusions of EORTC is that there is no benefit in administering chemotherapy after a patient gets chemotherapy and radiation and then surgery. But please note, the problem here is that only 43% of these patients completed their chemotherapy, and this is an intent to treat analysis. How about the Italian study that's frequently quoted, where they're using 6 cycles of 5-FU as opposed to FOLFOX? And again, the patients are doing poorly, they're not tolerating their treatment, and there is no difference in disease-free survival or overall survival. But again, only 48% of patients are completed chemotherapy. Proctor script, again, trying so hard to prove the benefit of chemotherapy after surgery. They're randomizing over 230 patients per arm, and there is no benefit at 5 years, either in overall survival or in disease-free survival. But only 77% of patients are completing chemotherapy. Only one out of all of these studies, it's the ADORE study that randomizes patients to FOLFOX, is able to show a slight benefit of administering chemotherapy after surgery. And what's different with this study, as you start sort of dissecting through the data, is that the benefit is only in the most advanced tumors, And another thing is, and it's just projecting funny because it was supposed to highlight the sentence, that 96% of patients completed chemotherapy. So somehow the clinicians in this study were able to get their patients through chemotherapy after surgery at a higher rates. But what all of that has led to is the thinking, well, so yes, okay, the data doesn't support the use of chemotherapy after surgery, but is that because chemotherapy doesn't work, or is that because getting a patient through the full course of chemotherapy at the doses that you would hope to administer is more difficult after surgery? And so that has led to some experimentation around the concept of administering the chemotherapy before taking a patient to surgery, so total neoadjuvant therapy. Again, the first question when you start changing your approach is that safe? And so the first trials in this domain were done at the Royal Marsden Institute in London. And what they've essentially looked at the safety part of this. And they took 105 patients, and they administered chemotherapy to them before surgeries. And then what they noted is only 12 patients, as opposed to half of their patients, were not able to complete their treatment, which is obviously a marked improvement from the standpoint of compliance. But then the question is, great, you've improved compliance, but does the surgery get more difficult? And that wasn't the case. Out of the 95 patients that went to surgery, 92 had R0 resections. So addition of chemotherapy before surgery did not impact the quality of surgery, which is obviously important. That was then followed up by a randomized trial, small trial, again, looking mostly at the concept of safety of administering chemotherapy before surgery. And in this case, it's chemotherapy and radiation following chemotherapy as well, so TNT. And what they are able to show is that there is no difference in terms of the risk as far as the quality of surgery afterwards. There is no increase in CRM positivity, so there is not increased fibrosis or some deterioration in the patient's tumor status that makes surgical outcome worse, and that going in that sequence is probably safe from that standpoint. The question, though, is, okay, it's safe. The compliance of patients with this regimen is better than if you're offering some of the treatments after surgery, but does it make a difference? And is it worth actually considering on a big scale? Is there any advantage as far as either local control or overall survival? And so this is when the big trials on TNT started in earnest. And there's many of them, but I think that the ones that are worth looking at in more detail are these three: the PRODIGE 23, OPERA, and RAPIDO. So PRODIGE 23, the data was just presented as ASCO. Some of you probably listened in, but I think it's worth discussing because it is the definitive trial from the standpoint of neoadjuvant chemotherapy. So what did they do? They randomized two arms. In one arm, the patients underwent the standard treatment where one starts with chemotherapy and radiation, then total mesorectal excision, and then after surgery, chemotherapy. So that's how we used to do things. In the second arm, they started with FOLFIRINOX first. Then, once the patient received a full course of chemotherapy, the patients were administered a full course of chemotherapy and radiation. And then, in about 7 weeks, they underwent total mesorectal excision. And in other words, the entire treatment, neoadjuvant treatment, was administered before surgery. So what happened? Well, obviously, you want to make sure you have your patients be eligible to chemotherapy and radiation. But apart from that, these were traditionally high advanced rectal cancer patients that up till now we've been able to improve their local control with adjuvant and neoadjuvant regimens, but have been failing to improve survival. And look at this. This is 7-year disease-free survival rate, which is higher in the patients that were administered TNT. 5-year overall survival rate higher. And essentially, if you look carefully, it is a difference of 5.73 months at 7 years. So administration of chemotherapy and then chemoradiation before surgery is finally showing a disease-free survival and overall survival benefit. That was the thing that we could never improve before. Same with the overall survival. And so the conclusions of PRODIGE 23, which mirrored smaller studies that I'm not putting up, is that in addition to improving local control, you could offer your patient a benefit in survival if you sequence your entire treatment and offer TNT before surgery. But what TNT sequence? Because you could do chemotherapy first, and then chemoradiation, and then go to surgery. Or you can do chemoradiation first, and then chemotherapy, and then go to surgery. And the terminology here is induction versus consolidation chemoradiation. And so some of the answers are coming from the Oprah study that's being run out of Memorial Sloan Kettering Center in New York City, where they are randomizing patients to either chemotherapy first followed by radiation, or radiation first followed by chemotherapy before the patient is restaged. And what's interesting about Oprah is that they're also looking at this whole concept of what happens if the patient has a complete clinical response after the TNT is administered. What if the tumor melts away completely? And in the Oprah trial, the patients who have a complete clinical response are not offered surgery. They are offered the watch and wait approach. And so the interventional arms, which are these two TNT arms, are then compared to the control arm that's getting the standard treatment, which is chemotherapy and radiation followed by surgery, followed by chemotherapy. So again, this is the data that was recently reported at ASCO about the 3-year results. And this is what's starting to come out, which is interesting. If you compare the chemo first versus the chemoradiation first TNT approaches, the disease-free survival by treatment group seems to be the same. So it doesn't matter if you start with chemo first or you start with radiation first. Patients do equally well. Same as far as the metastasis-free survival. Doesn't matter if you do chemotherapy first or chemoradiation first. But remember what I said, the trial also takes the patients that have a complete pathological response and observes them. And in this trial, when patients were offered TNT, 26% of patients did not go to surgery because they had a complete clinical response. And there was another group of 38% that had near complete response, and those were watched a little bit longer, and if they eventually had a complete response, they would undergo surgery, they would be watched, but if the incomplete response persisted, then they would undergo low anterior resections. And obviously, these watch and wait patients were watched very carefully with every 3-month endoscopy, every 6-month MRI, every 12-month CT scans, and every 4-month CEA. So incredibly careful surveillance, and if there was tumor regrowth, those patients would then immediately undergo total mesorectal excision. And so at 3 years, the organ preservation rates were 78%, so one out of 4 would recur and require total mesorectal excision, but 3 out of 4 would preserve their rectums after TNT alone. So again, now if you look at, does it matter if you do chemotherapy, then chemoradiation versus chemoradiation, then chemotherapy? Interestingly enough, starting with chemoradiation first increased the rate of clinical complete response and organ preservation. So what does that mean? It means that now when we are having conversations with our patients, and let's say this is a high rectal cancer tumor, and we think a low anterior resection will be straightforward, we would say, doesn't matter, you can start with chemotherapy and radiation, or you can start with chemo, and then we will do a total mesorectal excision. But if this is a patient that has an ultra-low tumor, the functional result will be terrible. The surgery will be really hard, and we are trying to see if we can get them to a complete clinical response. In that patient, we would advocate starting with chemotherapy and radiation, then following up with chemo to see if we can increase their complete clinical response rate and avoid surgery. And I know that Dr. Poylin has more on organ preservation and watch and wait, so I'm not going to belabor this topic, but it's just important to realize. And so the summary from Oprah was that the treatment plan that includes TNT allows for a pretty significant rate of organ preservation if that's your goal. But if your goal is to proceed with surgery, then there is no difference in overall survival, disease-free survival, metastatic development in the patients that go either way as far as the sequence of the TNT, induction versus consolidation. But I'd also want to point out that if you take everyone and you administer TNT, as in Prodigy, and then you do surgery, then there is actually a benefit to survival of 5 months. Whereas if you take everyone, you administer TNT, and then you go with the watch and wait protocol, it's the same survival, not better survival. So you are sacrificing something when you're not offering surgery. Surgery does have a benefit. And so it's a very careful discussion with the patient about, do these 5 extra months matter to you enough that you want us to take you through a big operation and a diverting loop ileostomy, et cetera, if you have a complete pathological response. And I have patients that might be elderly, might be frail, and they say, you know what, I'd prefer to keep my rectum and I will give up my 5 months. And then I have super young patients that have a complete clinical response, and they may elect to have surgery even with a complete clinical response. So it's gotten harder to take care of rectal cancer patients because now all of these conversations have to take place. The last trial that I wanted to mention, and again, there's many other, but these 3 I think are very important, is the Rapido trial, where, again, the question was, what's the role of TNT in the patients with rectal cancer? But in this study design, they compared the traditional approach of administering chemoradiation first, then surgery, then chemo, to the approach where the patient is offered a short course of radiotherapy of 5 times 5 gray, and then Capox, and then surgery. And obviously there are lots of advantages to offering the short course. The patient only has to suffer through radiation for 5 days as opposed to 5.5 weeks. They don't have to commute as much and come every day to the hospital, et cetera, et cetera. So what is the outcome? And, the initial results were very nice because what turns out that if you do chemoradiation short course first, then chemo, there was a doubling of the complete pathological response rates. So the patients that had chemoradiation first had more shrinking of the tumor. And so if your goal is organ preservation, doubling of the complete pathological response rate is a great outcome. The experimental arm had better disease-related treatment failure, fabulous, and decreased rates of distant metastasis, fabulous. But look at this, and the overall survival, better, right, great. And this is what I'm calling the Rapido paradox. For some reason, despite all of these great things, the local recurrence rate in the experimental arm that received chemotherapy and radiation followed by chemo was worse. What's going on? Well, it's us, the surgeons. Essentially, if you do chemotherapy and radiation first and then chemo, the surgery gets a lot harder. More blood loss and more R1 resections. And so if your goal is to then go to surgery, then doing short course radiation, wait while the chemo is administering, and then going to surgery is going to make your surgery much harder, and you may compromise the oncological outcome locally, even though you are sterilizing the lymph nodes, even though you have a better complete pathological response, et cetera. So what's that all mean? Well, essentially looking again back to back at the Prodigy and Rapido, with Prodigy, where everybody goes to surgery and gets chemo first as opposed to radiation first, you have improved survival, improved recurrences, and sustained local recurrence rates that are not worse. Whereas with Rapido, you have equivalent survival, not improved, equivalent local recurrence rate, and worsened local recurrence rate. And so again, when I have these conversations with my patients, I say, if you are trying so hard to spare your rectum that you want me to do chemotherapy after your chemoradiation to increase your pathological response, you might be putting yourself at risk if you're not lucky and you don't have a complete pathological response, and we have to take you to surgery, because then you may be compromising the quality of your operation. And so remember I said the NCCN guidelines just changed recently. And what's changed is that now, for us in America, the recommendation is to offer TNT routinely. We used to do chemotherapy and radiation, then surgery, and then adjuvant therapy. Now that's off the books. The recommendation is that everybody get TNT in whatever sequence you choose based on your goal. If your goal is organ presentation, you can do radiation first. And if your goal is improving disease-free survival and overall survival, but then you're still planning on surgery, then doing chemotherapy first. Another thing that's different now is, and I'm crossing out the short course because I have the prejudice that I think, probably it's worth working towards improved overall survival as the goal. And another thing that's now officially on the NCCN guidelines as opposed to being considered questionable is the watch and wait approach. So more and more we in the United States are seriously having these conversations with our patients about observation and monitoring. So to conclude, rectal cancer surgery, rectal cancer treatment, the algorithms of care in terms of administering medications are rapidly evolving. But for the first time in 20 plus years, there is a glimmer of hope that we're starting to figure out how to improve the overall survival of these patients. We still have a long way to go. 5 months is not enough. We need, 5 years, 10 years, 20 years. And that probably, the answer is probably going to lie in improving the actual medical regimens that we're administering. But I do think that the neoadjuvant approach of administering most of these medicines before we go to surgery is going to be the way forward. And thank you very much, and I'm ready for questions.
Можливо, є якісь запитання? Швиденько, якщо. Так, бо нас чекає хірургія зараз. Та-та.
Thank you very much for your great talk. I have a question regarding the watching strategy. So for how long do you watch in this intensive schedule? I mean, every 3 months, colonoscopy and so on.
I'm happy to answer this, but there's also another talk that Vitaliy Poylin is going to give when he gets back, and I'm sure he'll give you even more detail, but I'll answer your question. So generally, we do it in the first 2 years after the patient. So first you examine your patient immediately after the chemotherapy followed by chemoradiation was administered, but not the next day. Usually it's about 6 to 8 weeks later. If the tumor is palpable, you're making sure that there is no palpable tumor left. You do an endoscopic assessment, usually with narrowband imaging, so that you can really make sure that there is nothing there. And you do an MRI. If all three are reassuring, then we offer the patient the choice of watch and wait. And even though there is now supportive enough of convincing data in this regard, there is always a conversation with the patient about the fact that 1 out of 4 will recur, and that there is the concern for the potential spread of metastatic disease while the tumor is persistent there, and we're not seeing it on our imaging or during our exam. If the patient agrees to watch and wait, and all of these signs are reassuring, then we would perform the same exam with endoscopy every 3 months for 2 years. And I have the endoscopy equipment in my office, so it's not as difficult. They just come in for a clinic visit, and I do the endoscopy in clinic. And then we'll do an MRI every 6 months for 2 years. And so the patient has to be willing to come back this frequently. Then, for the next 2 years, we will do a clinical exam with endoscopy every 6 months. Again, that's a clinic visit. And then an MRI every year. And then after that, 2 more years of yearly exams. So we go up to 6 years.
Okay,
So
thank you very much.
very intense, and obviously not ideal if a patient is coming from far away, if they're going to be non-compliant with their follow-ups, etc.
But maybe it's worth it to preserve the
Right,
organ.
and usually the recurrences are we don't call them recurrences, we call them regrowths. Usually the regrowths are in the first 2 years. Sometimes they can happen further out, but the first 2 years are the riskiest ones. That's why we do it so quickly, so frequently. And the surgery in the regrowth setting is not as horrible as surgery after a local excision and regrowth, because the regrowth is usually luminal, so you can catch it before they are invading the margins and become unresectable. So the rates of unresectability are actually not that high. And so that's why it's different from a local excision follow-up in terms of the risk.
And really quick, another question. Is the strategy for microcytal and unstable tumors the same, or you move to immuno?
Immunotherapy, for sure, yes.
Small question, if possible. In this situation, when you have complete response, and from the point of view of economical effect, and because a lot of follow-ups during 5 years, as I understood, and from the point of view of calmness of patient, yeah, because I wouldn't know what would I choose if it would be me.
Exactly.
Yeah. So, how do you think? Is it okay to provide this strategy like officially, to like recommendations to the whole world?
So, if you look back at that algorithm, it's not mandated to do watch and wait. It's an option to do watch and wait. And so it's really a conversation with each individual patient. And honestly, if the tumor is mid-rectum or upper rectum, I would be more encouraging of the patient to undergo surgery because, if you look at PRODIGE, there's an overall survival benefit, right? But if you have an ultra-low tumor and the surgery will be an abdominal peritoneal resection or an ultra-low LAR with large symptoms, et cetera, then the conversation balance changes a little bit. And we offer the patients the choice. And not everybody chooses watch and wait. I have many patients that have the conversation, come back, ask more questions, come back, ask more questions, and then like, you know what? I'd like surgery, thank you very much. And we do the surgery. And then I have other patients that have high rectal cancer tumors, and I try so hard to convince them to have surgery, but they're like, no, I want watch and wait. And so now it's really patient by patient by patient. So the conversations are getting longer and longer and longer.
Thank you so much for your brilliant presentation. You gave a lot of new for me and myself, I think, to other people in this hall. Ми можемо включити?
Значить, тема досить актуальна, переважно для клінічних онкологів, тому що хірурги з цим стикаються досить рідко, хоча деякі хірурги також проводять системну терапію, тому, в принципі, є доволі актуальним. На сьогоднішній день для перша і друга, трошки повернемось так, значить, колоректальний рак, зрозуміло, проблема актуальна, займає 3-е місце по захворюваності і по смертності серед обох статей. І що важливо розуміти, що метастатичний процес зустрічається, по-перше, в 20% первинно діагностованих пухлин, а також, як ви можете бачити з вказаного дослідження, що при другій стадії близько 10% пацієнтів із раком ободової кишки будуть мати прогресію впродовж перших 2 років, і переважна більшість, тобто можна бачити елевацію цієї частоти навіть на першому році. При прямій кишці ця частота ще більша, це 17% при другій стадії радикально лікованій, і при 3-й стадії це 31% і 40% відповідно. Тобто у нас в структурі метастатичного захворювання є відповідно 2 проблеми – це первинна метастатична хвороба, а також рецидив радикально пролікованої терапії. І вже в залежності від того буде стояти питання подальшої терапії. Якщо від прогресії, якщо це була радикально лікована пухлина, і від прогресії пройшло менше, ніж півроку, відповідно, ми ту схему, яку використовували в якості неодювантної або адювантної терапії, ми її втрачаємо для опції лікування метастатичного захворювання, і це може рахуватися як перша прогресія. Якщо пацієнт був лікований більше, ніж півроку тому, в принципі, ми маємо справу як з первинно-метастатичною хворобою, тому подальша тактика буде схожа як на первинно-метастатичний процес. Дуже відомі всім, я думаю, схеми, тобто це стандартний підхід для мікросателітно стабільних пухлин ободової та прямої кишки для вибору тактики першої лінії. За останні роки трошки змінилася парадигма для вибору і стали інколи обирати для першої лінії фолфірінокс, і з бевацизумабом, якщо немає до нього протипоказів. Ця схема, що цікаво, показала досить непогані результати по загальній виживаності пацієнтів, навіть у порівнянні, якщо лікувати послідовно фолфоксом, далі фолфірі або фолфірі, потім фолфоксом. Проте на сьогоднішній день ще не всі ризикують використовувати дану схему в першій лінії, щоб не втрачати подальшу після прогресії, для того, щоб ми могли обрати подальшу тактику лікування. І, в принципі, друга лінія залежить від того, що було обрано в першій лінії. Відповідно, якщо перша схема була обрана з використанням оксаліплатину, в другій лінії буде використовуватися іринотекан. Якщо використовувався іринотекан, відповідно буде використовуватися оксаліплатин, якщо немає відповідних протипоказань. І також дуже бажано використовувати як в першій, так і в другій лінії препарати таргетної терапії для інтенсифікації. Це можуть бути інгібітори IGFR для пухлин лівої половини ободової кишки, які не мають мутації у генах KRAS і NRAS, і це можуть бути препарат VEGFR-інгібіторів, до яких відносяться бевацизумаб або будь-які зареєстровані біоаналоги, для незалежно від мутації наявності або відсутності і незалежно від половини кишки, чи це права ободова, чи це ліва ободова кишка. І надалі, так, для того, щоб було розуміння, я винесла зноску, яка дається щодо третьої лінії лікування, що на сьогоднішній день те, що вказано в крайньому стопчику, це рекомендується використовувати після всіх можливих для даного пацієнта видів лікування. І також хочу зазначити, і про це вкажу також пізніше, що на сьогоднішній день комбінація в третій лінії хіміопрепарата з таргетним препаратом переважає по ефективності та по бажаному ефекту перед монотерапією. Тому якщо немає протипоказів до використання таргетної терапії, бажано її використовувати. І ми підходимо до нашого квесту, що робити з пацієнтом, який отримав, в принципі, фторпіримідини, іринотекан і оксаліплатин у попередніх лініях, що з ним робити далі. Далі починається творчість і трошки додаткових молекулярних обстежень. Відповідно, якщо пацієнт не має жодної драйверної мутації, для якої можливо використовувати існуючі таргетні препарати, для пацієнта треба використовувати ті існуючі хіміопрепарати, які показали ефективність для лікування колоректального раку. Це може бути як інтенсифікація терапії, відповідне застосування триплету, якщо попередньо були використані дуплети, так як, знову ж таки, повертаючись, комбінація фолфірінокс навіть після попередньо використаних всіх складових показує інколи результати, особливо у молодих пацієнтів, але особливо у молодих, тому що у молодих частіше за все можна її використати, тому що літні пацієнти, підходячи до третьої лінії лікування після 2 прогресій, частіше за все не можуть фізично вже переносити таку інтенсивну терапію. І також у нас в резерві є препарати регорафеніб і препарат трифлоридин тепірацил, які були відносно нещодавно зареєстровані, порівняно з іншими препаратами, які використовуються при лікуванні колоректального раку, були нещодавно зареєстровані і з 2021 року входять у третю лінію лікування пацієнтів з колоректальним раком, які, на відміну від цих попередніх досліджень, показали покращення загальної виживаності і безрецидивної виживаності у пацієнтів. І окрему групу також складають пацієнти, які все ж таки мають драйверні мутації і для яких можна застосовувати таргетну терапію. Мені дуже подобається дана схема, що на ній можна побачити, наскільки в останні роки розвинулось вивчення молекулярної структури колоректального раку. Можна побачити, що в середині попереднього століття впродовж 30 років не було жодного препарату, окрім 5-фторурацилу, для лікування пацієнтів із пухлинами товстої кишки. І чим ближчим підходимо до сьогоднішнього дня, тим з більшою частотою знаходять нові точки прикладання для лікування колоректального раку. Але, тобто це все дуже чудово, і нам здається, що у нас є величезний арсенал ліків, з яких ми можемо вибирати, але воно трошки не так, тому що, по-перше, більшість цих препаратів, точками прикладання для них є мутації, дуже специфічні, і вони дуже рідкі за своєю частотою у пацієнтів з колоректальним раком. Тобто, частіше за все, у пацієнтів немає тих мутацій, на які ми могли б як-небудь діяти. Це перша проблема. Друга проблема, яка стосується, в принципі, країни, регіони нашого проживання, багато препаратів банально недоступні для пацієнта в жодному вигляді, тобто вони не зареєстровані у наших широтах, і переважно вони показали свою ефективність у дослідженнях першої, другої фази. Частіше за все це Сполучені Штати Америки. В кращому випадку це дослідження, які проводились в декількох ще країнах на території Європи. І дійсно, підхід на початку, коли виявили, що ми можемо після винайдення перших мутацій в злоякісних пухлинах, здавалося, що шлях знайдений, що всі пухлини мають якісь мутації, в принципі, теоретично можна синтезувати молекулу, яка буде на них діяти, і це буде давати чудову відповідь. І ось, наприклад, в 2015 році в журналі Nature була опублікована стаття, яка була присвячена різновидам молекулярного ландшафту колоректальних пухлин. І ми можемо бачити, що було виявлено, що є мутація, є таргетний препарат, але не так виявилось, як хотілося б, що дуже часто блокування цих мутацій не дає бажаного результату на ефективність лікування. Тому що є певні інші білкові ланцюжки, за рахунок яких пухлина може розвиватись. І тут ви можете побачити, що по частоті з тих мутацій, на які ми дійсно можемо якось впливати, їх не так багато, тобто відсоток менше 10. Це може бути або мікросателітна нестабільність, це не зовсім мутація, але це певна молекулярна характеристика пухлини, на яку ми можемо діяти імунопрепаратами. Це з потенційно ефективних може бути BRAF-мутація, куди застосовуються комбінації BRAF-інгібіторів і показують потенційно ефективні результати. Це може бути мутація у гені HER2/neu, але знову ж таки для колоректального раку це не більше 2% пухлин мають цю мутацію. Також туди застосовується комбінація з 2 HER2-інгібіторів, один з яких в обох комбінаціях не зареєстрований в Україні. Тобто ми зараз маємо тільки трастузумаб і пертузумаб. Для кишки застосовується тільки трастузумаб, і то в комбінації ще з іншими молекулами, які впливають на HER2. І також ми знаємо про мутацію KRAS, але поки що єдине ефективне застосування цієї інформації нам дає те, що ми не призначаємо KRAS-мутованим пухлинам інгібітори EGFR, так як вони не дають ефекту. Проте, нещодавно було виявлено, що один з підтипів мутації KRAS в локусі G12C, він є, на нього можна діяти за допомогою препарату, який блокує безпосередньо цей локус у цьому гені. Це було показано на пухлинах легень, проте потім це інтерпретували на колоректальний рак. І якщо ми блокуємо безпосередньо ось цю мутацію, це дозволяє нам у таких пацієнтів використовувати препарати групи EGFR-інгібіторів. Дуже показовим прикладом є дане дослідження, яке було опубліковано на щорічному з'їзді АСКО в цьому році. Ми можемо побачити, що застосовується у пацієнтів, які отримали вже множинну терапію і дали прогресію. У 3-й або 4-й лінії можна застосувати суперінтенсивну терапію з 2 таргетними препаратами і 2-компонентною хіміотерапією. Воно було досить показово, з хорошим результатом. Ви можете бачити, що це дослідження першої Б-стадії, тобто зовсім раннє, воно ще не має достатнього рівня доказовості для того, щоб входити в стандарти. Але ось, тобто це чудовий приклад прикладної молекулярної науки. Але один препарат не зареєстрований в Україні. Соторасіб – це саме препарат, який блокує в локус G12C. Другий препарат поки що не реімбурсується державними клініками в Україні. Це препарат панітумумаб групи GFR-інгібіторів. І, як я вже казала, що багато пацієнтів, які доходять до третьої лінії терапії, вони вже ослаблені. І давати їм 4-компонентну терапію, це вже є, не всі її можуть потенційно перенести. Це один мінус. Другий мінус, як ви можете бачити, частота KRAS мутації в гені G12C складає всього до 4%. Тобто це доволі рідкий вид мутації. Це один мінус. Другий мінус. На даному слайді ви можете бачити частоту появи колоректального раку в залежності від віку. І найбільша кількість пухлин все ж таки виникає у пацієнтів старшої вікової групи на сьогоднішній день. Тобто пацієнти, які дійсно потенційно фізично можуть на момент третьої лінії бути достатньо фізично підходящими для інтенсивної терапії, їх не так багато. І все одно у нас залишається питання того, що призначати пацієнтам, яким вже проведена максимально доступна на той момент терапія інтенсивна, тим паче, якщо вони літні, тим паче, якщо вони ослаблені попередніми курсами. І відповідь ми отримали також на АСКО цього року. Вона була у вигляді публікації результатів дослідження Sunlight, в якому було показано потенційну ефективність і вплив на загальну виживаність і безрецидивну реживаність комбінації двох препаратів. Це препарату трифлуоридин-тепірацил з бевацизумабом. Порівняння проводилось із препаратом трифлуоридин-тепірацил у монорежимі. Пацієнти були рандомізовані незалежно від факторів ризику, тобто вони всі потенційно мали б змогу фізично отримувати препарат бевацизумаб. Проте варто зазначити, що в реальному світі не всім він показаний, так як цей препарат має доволі сильний вплив на стінку судин, і у пацієнтів, які мають серйозні кардіоваскулярну патологію або мають в анамнезі інсульти, їм не показане застосування цього препарату, тому так допустимо для цієї категорії пацієнтів використовувати і монотерапію, так як вона також дещо покращує загальну виживаність і безрецидивну виживаність. І паралельно з презентацією на АСКО була опублікована відповідна стаття у New England Journal of Medicine, в якій також було показано, що у пацієнтів, які отримали вже інтенсивну терапію, застосування дуплету трифлуоридину тепірацилу з бевацизумабом покращує виживаність при доволі лояльному рівні токсичності. І те, що там показувало дещо раніше, що в дослідженнях цього не було показано, але є формат вивчення, аналізу даних, який називається Real World Data. Це те, що береться до уваги саме реальна практика, використання даних, які кажуть лікарі, які дійсно практикують поза рамками клінічних досліджень. І за спостереженням онкологів, це були європейські онкологи в даному випадку, що токсичність трифлуоридину тепірацилу є дещо кращою, меншою, ніж при застосуванні препарату регорофеніб, який також іде в стандарті третьої лінії терапії. Із своєї практики можу підтвердити, так, дійсно, що препарат регорофеніб має досить виражену шкірну токсичність, пацієнти мають виражену висипку, більш виражений долонно-підошвовий синдром, тому інколи для ослаблених, тим паче пацієнтів, цей вид лікування не завжди є достатньо підходящим саме в плані їх фізичного стану. Тобто воно потенційно може погіршити якість життя, навіть подовживши тривалість цього життя. Із переваг даного лікування – це те, що всі препарати, в принципі, і регорофеніб, трифлуоридин, тепірацил і бевацизумаб зареєстровані на території України, тому пацієнти, які зараз не мають змогу виїхати за кордон для подальшого лікування або не мають відповідних мутацій, щоб отримати таргетну терапію, вони можуть отримувати це лікування на території України. Я дякую вам за увагу, і якщо у вас є питання, я готова на них відповісти.
And with a great pleasure, I want to present you next our speaker, our colleague from Northwestern, with presentation about possibility of immunotherapy for colorectal cancer. Please, Dr. Aparna Kalyan, if I'm not mistaken pronunciation, sorry for that. Ми робимо трансляції всі сьогодні, дякуючи нашим колегам наживо, як то кажуть. Тобто ви можете в чаті писати, хто дивиться питання. Ми далі відмодеруємо ці питання нашим колегам. Тобто ніхто з американців та європейців не виступає в записі. Ми їм дуже дякуємо за це. І, будь ласка, наступна презентація.
Thank you so much for giving me this opportunity to speak in front of you. I sincerely appreciate it. Thank you so much for this opportunity to speak in front of you. I just wanted to give you a little overview today of immunotherapy and colon cancer in terms of where we're at. So many of us are familiar with microsatellite stable tumors and microsatellite unstable or MSI high tumors. The big difference between these two tumors tend to be that microsatellite stable tumors are immune excluded, or what we call immune desert tumors. So there is no immune response either because there is an absence of T cell presence as seen here, or even when there is T cell presence, there's a very hostile tumor microenvironment, which makes response of immunotherapy or response by the immune system very difficult. On the other hand, microsatellite high tumors are heavily mutated tumors, and these are very prone to immune attack because of the tumor microenvironment being very friendly towards immune checkpoint blockade. So why is microsatellite high so important in colorectal cancer? As many of us know, it is important for both Lynch syndrome diagnosis and screening, which then has significant impact in not just for colorectal cancer, but for other cancers as well. It is a prognostic marker. It is predictive biomarker for both response to neoadjuvant and adjuvant chemotherapy. And perhaps most importantly, that is pertinent to this talk, is that it is a very important predictive biomarker for the response of immunotherapy. What we do know is that in microsatellite high tumors or MMR deficient tumors, the number of neoantigens that are present is very high, which then in turn leads to an environment that is very friendly for cancer, for presentation to the CD8 positive cells, which then leads to an immune response. So this is what allows us to be able to utilize medications like a PD-L1 blockade or a CTLA-4 blockade, which subsequently leads to tumor cell killing. You might have seen this graph before. So now when we look at the number of somatic mutations across the objective response rate here, what we can see is that across all histologies, there are certainly some tumors that tend to be very mutation driven, and then there are some that are very mutation quiet. And within colorectal, there is actually two distinct groups that you're able to see. So down here, we have colorectal cancer that is MMR proficient. And then on the other hand, we have up here colorectal cancer that is MMR deficient. And what this is really saying is that if you have a microsatellite stable or MMR proficient colorectal cancer, these do not have a lot of somatic mutations, which in turn has a lower objective response rate across the board. Alternatively, when you have a MMR deficient colorectal cancer, the number of mutations seen is significantly higher, which again corresponds to a much better response rate. So the takeaway is that higher mutation burden translates to a better response from immunotherapy. And this is important because in these MMR deficient colon cancer patients, we see significantly higher mutation burden compared to any other cancer in the GI tract. So currently we have three available checkpoint inhibitors that we use routinely in colorectal cancer. Ipilimumab, which is a CTLA-4 inhibitor, nivolumab, which is a PD-L1 inhibitor, and pembrolizumab, which is also a PD-L1 inhibitor. And What this cartoon is really saying is that when you have this interaction between a cancer cell and the killer T cell, and this PD-1, PD-L1 is blocked, it allows for a death, cancer cell death to occur, which then leads to a better response from a cancer standpoint. So one of the very first trials that looked at this question was Keynote 16, and this was back in 2015 when immunotherapy was sort of still in its infancy. And this was a phase 2 study where they had patients across all cancer types who had progressed on multiple lines of treatment, and they enrolled both MMR proficient and MMR deficient cancers. And if I can just draw your attention to this waterfall plot up here, what clearly it stands out is that the MMR deficient cancers, regardless of whether it was colorectal or non-colorectal, had a significant response as seen by the graph here compared to the MMR proficient tumors. Now, if you walk across and we look specifically at the colorectal cancer group here, again, what this translates to on this side is the responses that we see, both that are partial response, stable response, is significantly higher compared to MMR proficient. In fact, 9 out of the 10 patients that were MMR deficient colorectal cancer patients had some sort of a good response here. So when you look at the cohorts in terms of PFS and overall survival, what we can see is that in the MMR deficient group, the PFS had not been reached and neither had the overall survival at the time of data cutoff. Keeping in mind that this is a heavily pretreated population, this is a very unique and sort of outcome that was unexpected. So in fact, the overall response rate for this was about 40%, and a PFS ultimately was about 78%. So the expansion cohort then enrolled about 86 patients, and specifically who were all MMR deficient. And if you look here, what stands out is the red graph in the pie chart, and the red stands for colorectal cancer. So majority of the patients who were enrolled were colorectal cancer patients. There was roughly about 48% who were Lynch syndrome, and the remaining were non-Lynch patients with MMR deficient tumors. And what you can see immediately is the profound response that we see in these patients. And again, if you look at the table, it corresponds to a disease control rate across all of these tumors around 77%. And specifically, if we look at the colorectal cohort, it was around 52%. And this is really what led us to understand that MMR deficient tumors are different and they potentially respond in a different fashion compared to standard tumors. This ultimately led to a larger study that was done across several countries, the Keynote 164. And what this is showing here in cohort A and cohort B is MMR deficient colorectal cancer patients. And cohort A patients had at least 2 lines of therapy, and cohort B patients had at least 1 line of therapy. And regardless, what this says again is that the disease control rate is relatively similar in the realm of about 50 to 57%, and the disease overall response rate is around 30%. And this is ultimately what led to the approval of pembrolizumab as a first histology agnostic immunotherapy to be for treatment of MSI high or MMR deficient cancers. Following this, there was a larger study that was done. This is the Checkmate 142, and here I'm just presenting the long-term data. This was initially started out as a phase 2 study, and it's since been broken down into 3 cohorts. I'm just going to walk you through the 3 cohorts in terms of what it ultimately leads to. So these are histologically confirmed metastatic recurrent colorectal cancer patients who are all MSI high, as done locally. Patients were then randomized into 3 cohorts, depending on the line of treatment that they were on. If they were second line or beyond, there were a group who received monotherapy with nivolumab alone, which is a PD-1 inhibitor. There was a group of patients who were second line and they received combination therapy with ipilimumab and nivolumab. And lastly, cohort 3, patients who were newly diagnosed who received ipilimumab and nivolumab. And patients were continued on this treatment until either progression or intolerance. And the primary endpoint of the study was to look at the overall response rate per investigator, along with disease control rate, duration of response, PFS, and overall survival. So I'm going to walk you through each of these cohorts now. So cohort 1, if you recall, this is patients who had had 2 lines or more of therapy. And if I draw your attention just to the objective response here, you can see that the response rate in this patient population is roughly around 31%, both by local assessment as well as by central assessment. And this is with monotherapy alone. Now, when we look at cohort 2, which again was second line and beyond, but patients in this setting received both nivolumab and ipilimumab, so dual checkpoint inhibition. And clearly you can see here that there is an automatic improvement in the overall response rate to 65%. And this sort of holds true all the way across to 15 months. So the follow-up has been quite long, and this shows that there is durable response over time. Now, lastly, cohort 3, which was newly diagnosed patients, and these were patients who received the dual checkpoint inhibition with nivolumab and ipilimumab. And again, you can see here that the response rate is quite high, around 69% ultimately. So this tells us that why is this important? So Checkmate 142 sort of confirmed a few things for us. In extended follow-up of around 5 years, there's durable benefit and safety in patients who are MSI high or MMR deficient who receive combination of ipilimumab and nivolumab or just nivolumab alone. So the overall response rate that we saw was around 31% in the second-line monotherapy group, 65% in the second-line dual inhibition group, and 69% for the first-line ipilimumab nivolumab group. This then concluded the support that treatment recommendations of both first and second-line treatment and beyond treatment with nivolumab and ipilimumab is appropriate for this patient population. There is an ongoing study, which I'll highlight later, that is looking at this question of how do patients do in comparison with chemotherapy in newly diagnosed patients. So if you recall, Checkmate 142 was a phase 2 study, which then led us to doing a larger study, which is the Keynote 177. Similar patient population to what we had looked at previously. So this was MSI high stage 4 colorectal cancer patients who were treatment naive, randomized to receive either pembrolizumab alone for up to 35 cycles or investigator's choice of chemotherapy. The study did allow for optional crossover to the pembrolizumab arm if patients had centrally verified progression. And they were continued on study until unacceptable toxicity or progression or withdrawal by the physician. And the endpoint of this study was actually PFS and OS combined. In addition to that, they also looked at duration of response and overall response rate. Just drawing your attention now to the graph on the left-hand side. What we can tell here is that in the pembrolizumab group, the overall disease control rate, so this is patients who have a complete response, partial response, and stable disease, is roughly around 43.8% compared to 33% in the chemotherapy group alone. Now, the number of patients who actually had a complete response is quite high in the pembrolizumab arm alone. And this again translates in the PFS when we look at it, with the median PFS being 16.5 months for the immunotherapy arm, which is statistically very significant compared to chemotherapy alone. And now when we look at the time to progression, again, what this highlights is that this is durable response that we see over time, over several months. So this is looking at close to 60 months from randomization, and patients are still getting benefit on this treatment. And as I said before, the PFS showed benefit. And then when you look at the median overall survival, again, there is 36 months in the chemotherapy arm. And actually at the time of data cutoff, they hadn't reached or the median overall survival had not been reached in the pembrolizumab arm. Now, there was crossover allowed. So how many patients crossed over? So there's about 56%, 56 out of the 154, so 36% of patients in the chemotherapy arm who crossed over to receive pembrolizumab after disease progression was confirmed. And in addition to that, there was another 37 patients. So essentially the crossover rate was about 60% in the intention to treat population who ultimately ended up receiving pembrolizumab. When we look at the breakdown of the tumor response, what we see here is that the patients receiving complete response was significantly higher compared to chemotherapy. And this, again, for patients who are metastatic, this is quite impressive. And the responses that we see, again, once again, we see are durable beyond 24 months. When we look at the overall survival across all the key subgroups, what stands out here is that all of them favor pembrolizumab. Specifically, if we also look at the population of patients who are BRAF, either BRAF wild type or BRAF mutated, again, it favors the pembrolizumab group. Perhaps one of the important questions that we always have to deal with is how patients feel. So health-related quality of life is very important for these metastatic patients. And this study did look at that. Out of the 300 patients who were enrolled, close to 294 patients completed the health-related quality of life. And what this graph is really showing is that in this first graph here, if it is below the line, it is showing worsening symptoms, as opposed to where it is above the line, where there is improvement of symptoms as seen. So clearly the pembrolizumab arm does show that there is improvement in functional status across all of these scales that they're looking at. And then when you look at the symptoms, once again, there is an improvement in symptoms in the pembrolizumab compared to the chemotherapy arm. Now, while this alone is not, it wasn't powered to look at this, I think what this confirms is that there is a meaningful improvement in quality of life, which is an important measure that when we look at these patient population. So it confirms that immunotherapy, specifically pembrolizumab in this setting, gives us durable responses that are meaningful and improved quality of life for patients. So Keynote 177 confirmed that there was a statistically superior PFS in the patient population across all subgroups. There were fewer treatment-related adverse events with pembrolizumab compared to chemotherapy. Pembrolizumab monotherapy provided a meaningful improvement in health-related quality of life compared to chemotherapy. It is limited because this was not a powered study and it's exploratory. And treatment with pembrolizumab compared to chemo is associated with a non-statistically significant reduction in mortality. There was a high crossover rate from the chemotherapy to PD-L1 arm, which again should be noted when we interpret these results. So we've talked about metastatic disease and why immunotherapy is important in the population of MMR deficient colorectal cancer. So what about localized disease? I think this is a very interesting space because given the responses that we've seen with immunotherapy, it does offer a newer concept of how we can look at these patients. Perhaps there is a potential for non-operative management in localized disease. Perhaps it is feasible to watch patients with colonoscopic surveillance. And importantly, I think there is a difference between colon and rectal cancer treatment, given how we manage rectal cancer across the board, and there is a risk benefit that we see. I think there is this discordance between radiographic and pathologic discordance, potential for over-treatment when we do neoadjuvant therapy, particularly with rectal cancer. And then perhaps we can think about strategies such as neoadjuvant surgery for patients who have a less than optimal response to immune checkpoint inhibition and subsequently continuing them with immune checkpoint. Now, these are all exploratory, but I think it does open up this realm which we weren't able to look at previously. What does remain unclear, however, is the optimal duration of checkpoint inhibition. All of these studies have used variable endpoints, so I think that is something that needs to be looked at. And what we didn't talk a lot about, which I know has been looked at by other people, is the role of ctDNA and other predictive biomarkers when we look at the responses to immune checkpoint inhibition. I did want to talk a little bit about rectal cancer. Rectal cancer has historically always been looked at with radiation, chemotherapy, and then this question of watch and wait, depending on the disease, is more of a newer strategy. While there's not a lot of patients who have MSI high rectal cancer, there is a population of patients who fall into this group. Now, this study came out at ASCO last year, and I think sort of really changed the way we look at MSI high rectal cancers. So in this study, they enrolled roughly about 30 patients who were MSI high rectal cancer, locally advanced rectal cancer, who had radiologic and endoscopic evaluation to start with, and they were treated with dostarlimab, which is again another checkpoint inhibitor, every 3 weeks for a total of 6 months. And based on endoscopic and radiologic evaluation, if they had a complete clinical response, they were then non-operative and followed up every 4 months. Alternatively, if they had residual disease, they were then treated in the traditional method of chemoradiation and followed accordingly. Now, what was, I think, perhaps sort of stood out to everybody was that there was an overall 100% clinical complete response. And this is sort of unheard of in cancer treatment. So this sort of really changed how we look at this. So these are across all of these patients who were enrolled, 14 patients at the time of presentation, all patients had a complete response. And when you look at the duration of response for these patients, it really, you see that there's an ongoing response that is still going on in these patients, even though the treatment was stopped at 6 months. Now, stemming from that, there are lots of studies that are trying to understand this population better. Granted, this is a small number of people that we see overall, but I think it does open up this question of non-surgical management of rectal cancer. Now, I do want to briefly highlight a few studies that are ongoing that potentially might change how we look at some of these patients too. So the NRG study is looking at the COMMIT study is looking at patients with MMR deficient colorectal cancer who are randomized to receive chemotherapy plus immunotherapy versus immunotherapy alone. And I think this will be interesting to see. Perhaps we are able to get away without chemotherapy in this population. And this is an ongoing study still. I had briefly highlighted this study earlier, and this is a Checkmate 8HW. Similar to the previous study, they're looking at MSI high cancer patients to receive either monotherapy with nivolumab or combination of ipi-nivo versus chemotherapy alone. And this is, again, an ongoing study that we're waiting to see what the results would be. The Atomic study has been going on for a while. So this is looking at the adjuvant space where patients who have confirmed stage 3 MMR deficient colorectal cancer are treated with either FOLFOX plus atezolizumab, which is another PD-1 inhibitor, for 6 months, followed by atezolizumab alone for an additional 6 months, versus chemotherapy traditionally for with FOLFOX for 6 months. And this really brings up the question of maintenance chemo with immunotherapy in this adjuvant space. And then lastly, the NeoPrism study, I think it's a busy slide, but I think they're trying to really understand how does ctDNA play a role in understanding MSI high tumors. And interestingly, this study has a unique endpoint of pathologic complete response in these stage 3 colorectal cancer patients who've been treated with pembrolizumab over time. And these are all sort of ongoing studies that I think would be very helpful to understand the population better. Stemming from the dostarlimab study, I think this ECOG-ACRIN study has been changed a little bit. The question has always been, do we need to give patients who are MSI high radiation or not? And I think dostarlimab study really answered that question a little bit. So this study is a rectal cancer patients who are T3 to T4 treated with ipi-nivo, and then if they have an excellent response, we'll just continue with non-operative management. However, if they have residual disease, there would be an addition of short course radiation to see how patients do. And again, this is an ongoing study to see how we can better manage MSI high rectal cancer patients. I think the takeaway points that are important from an immunotherapy standpoint for colorectal cancer is testing for mismatch repair deficiency at diagnosis for every stage of colorectal cancer is absolutely vital. It ensures adequate diagnostic knowledge and, importantly, screening tools if needed for Lynch patients, and opens up these options with immunotherapy. Immune checkpoint inhibition is a very helpful therapeutic strategy for the mismatch repair deficient colorectal cancer patients. Efficacy is increased the earlier the stage of the disease, as we've seen today. The toxicity profile is much more favorable for patients. As I mentioned earlier, there are, however, some points that we should keep in mind. We still are not very good at knowing who would be the person who responds to immune checkpoint inhibitor. Understanding the molecular markers. Is there a difference between Lynch versus non-Lynch? And what are some of the other tumor microenvironment factors that might impact or play a role in response? The optimal duration of therapy still remains unclear. We don't fully understand singlet versus doublet therapy and duration of therapy if we were to pick singlet or doublet. And as we understand more about circulating tumor DNA, and this would potentially offer an additional tool for us to see if we can better identify patients who respond to immunotherapy. I think from an oncologist perspective, I think checkpoint inhibitors may potentially spare patients from treatment modalities such as surgery or radiation, and still offer a durable response, and in some patients, even a curative option. So I think this is an exciting area. We just have to better understand some of the tools in terms of where we stand right now. With that, I will stop. Once again, I really do want to thank everybody for giving me this opportunity to talk today. I feel very honored. Thank you.
Thank you so much for so detailed a review of immunotherapy. This medication, unfortunately, a bit difficult in the territory of Ukraine. Most of medication are not under registration, and we can look at them only in clinical trials. But also the problem now because of war, but we're hoping the clinical trials will renewing and continuing here, and we also will have a possibility to touch these new treatments. We have one short question because we are a bit of time. Please.
Thank you so much for your presentation. I'm interested about ctDNA. Maybe you can have experience. Can you use ctDNA on the terminal stages. I mean stage 3 and 4 in this complex disease in colorectal cancer patients. So can we use it as a marker of prognosis or a marker of chemotherapy or immunotherapy? Maybe you know this information. Because basically it's for patients before we start treatment, yeah? It's a marker of answering to the treatment, efficacy of treatment, yeah? But can we use it on the patients with liver metastasis and so on?
I think that's a great question. We're trying to better understand that space. I think what we know is what we've understood from the adjuvant trials, where it's used routinely to see who recurs. We're doing a lot of trials trying to understand that population of metastatic patients. When we talk about giving patients a treatment holiday or a treatment break who are not doing very well, there is a lot of work being done into that. I don't know if I can tell you that that has been defined entirely. There's also questions about what do we consider as positive in metastatic space for ctDNA? Is it the same as patients who are being treated in the adjuvant space? So I think that area is still being understood and evolving continuously. So there are trials and ongoing use in terms of in the metastatic space with ctDNA. It is not routinely done. I think there is still this paucity of information about how to look at that data. So we don't routinely do it, but I've done it on study, and I do have trials that we're trying to understand the space of when to go to surgery, when should we stop treatment, because it is the optimal time to take a person who has liver mets to surgery. It's still being evaluated. So I guess the short answer is I don't have a clear timing, but I think as we understand it a little bit more over the next few years, we're going to get a better understanding of that.
Thank you one more time. We appreciate you with us at this time. Hope you will join to us in our next events, and we will move forward. Thank you. And our next presenter, actually from our mother organization, from European Society of Surgical Oncology, the president of society, Professor Geerard Beets from Netherlands Cancer Institute, with a presentation about recurrent rectal cancer. Please.
Hello, thank you for the nice introduction. And first of all, I want to send our best regards and support wherever we can from both the European Society of Surgical Oncology as well as the Dutch Society of Surgical Oncology. So my talk is on recurrent rectal cancer. I hope you can see my screen advancing. I have no disclosures. I first of all want to remind the audience of this Blake Cady quote that we probably all know, that outcome in surgical oncology is first determined by the biology. So biology is king, selection is queen, and technical maneuvers are the prince and the princess. So when you apply this to recurrent rectal cancer, I would first say we have to understand what type of disease we are dealing with. Selection is about selecting the proper patients and defining the treatment goals, and then we come to neoadjuvant therapy and surgery, and I will deal with these topics along the way. There is this other quote from one of the older surgeons, one of my teachers, that said, if you are going to operate recurrent rectal cancer, hopefully the previous surgeon did a lousy operation. Of course, this is a little bit cynical, but this says that there are very different types of recurrent rectal cancer with different types of outcome, and I will illustrate this. So a recurrent rectal cancer can occur because of a suboptimal surgical technique, or because it is really a bad tumor. And the outcome is gonna change. So the more it is from a surgical technique failure, the better the outcome, as illustrated by a case where you just have an anastomotic central recurrence, after a PME with a narrow distal margin. If you treat this correctly, this recurrence, the prognosis will be reasonably good, as opposed to the multifocal recurrence after TNT for this imaginary case whose EMVI plus perineural invasion, lots of lymph nodes positive. If you get a local recurrence, the outcome is going to be very poor, whatever you do. So this we have to keep in mind. Another thing that has been mentioned, and we've noted this in the Dutch TME trial, is that these are the survival curves for local recurrences in the TME only arm. That's the red line here. And after the radiotherapy and TME arm. And it's been said, this has been wrongly interpreted as radiotherapy complicates the treatment of recurrences, which is actually untrue, because when you see below here, radiotherapy prevents a lot of recurrences. So you're stuck with biologically unfavorable recurrences, and they do worse, of course, because radiotherapy prevents a lot of the more favorable local recurrences. If you see down there, it's especially good in preventing the prognostically good anastomotic recurrences. So you are left with a prognostically more unfavorable group. So it's a selection thing, not something bad from the radiotherapy. Another thing we noticed, we did a large regional cohort study some time ago on MRI-based treatment stratification, where we gave a lot of radiotherapy. I think 90% of patients got radiotherapy, and we were seeing a very low local recurrence rate, a good overall survival. And then we noted that, so we were doing a lot of radiotherapy, good TME surgery, and we had a low local recurrence rate, but it was no longer determined by technical factors, because most of the patients with a positive margin, few, they had no local recurrence, and those who had a local recurrence, none of them had positive margins. These patients who did get a local recurrence were mostly determined by bad biology, and they did very poorly. So these are the type of survival curves you see after curative resection of local recurrences of rectal cancer. And then you could say 40% is not very good, but it's still not very bad. But you have to remember that a lot of these patients with local recurrences are not operated. They have simultaneous metastatic disease. So this is a mixture on the right of the curves of patients who were not treated surgically. They do very poorly. So overall, the survival after a local recurrence is more like 20%. Once you are able to do a good resection, preferably R0 or R1, the outcome is reasonably good. If you do an R2 resection, an incomplete resection, that makes no sense, so you should avoid doing that. And when you compare the outcome of local recurrence rate to colorectal liver mets or peritoneal metastasis, this looks a lot like metastatic disease. Actually, colorectal liver metastasis have a better prognosis, the ones you operate, than local recurrence rate. So it's basically a poor disease. Now there are a lot of different types of recurrences, and there are many classification schedules. Mostly are MRI based. This is one where you have 5 or 6 compartments. We usually say central, lateral, and posterior. And this has some implications. First of all, this is from an older series. On the left side below, this is what we call a central local recurrence. It's growing into the prostate and the seminal vesicle. This is a lateral recurrence, and this is posterior recurrence. These are the main 3. This is an older series. There were a lot of central recurrences and sort of equally lateral and posterior, and then there were other types of recurrences. The central recurrences are prognostically more favorable, but when it's fixed and when it's symptomatic, that is prognostically unfavorable. If you compare the types of local recurrence, the outcome, anastomotic recurrence, they have the best outcome. Central recurrences reasonably well, but presacral and especially lateral local recurrences, they have a poor outcome. And the type has changed because with our increasing good TME surgery and the use of radiotherapy, we decreased the anastomotic recurrences and the central recurrences. And in modern series, what remains, half of the recurrences are lateral, difficult to treat and not so good outcome. What we also noticed that with organ preservation, we are seeing regrowths. We are seeing regrowths after local excision. We are seeing isolated nodes in the mesorectum after organ preservation, as you can see here. And after TME, we are seeing multifocal recurrences there. They're very difficult to treat also. So good imaging is essential. You need a high resolution MRI and preferably in 3 planes, because here you see a lateral recurrence, which is probably close to the lumbosacral plexus or the ischiatic nerve, but it's difficult to tell. What is good for these cases are the coronal views, because here you can see actually very well where the sciatic nerve is and where the recurrence is encroaching on the sciatic nerve. Actually, if you want to resect this, you will have to resect a part of the sciatic nerve. And you need to see that. You have to be prepared to do that. You have to discuss this with the patient before. So good imaging, good MR imaging. Then the decision making, are you going to take this local recurrence on or not? So the type of recurrence, if it's prognostically more favorable, you're more inclined to do a local treatment. If the interval is long, it's better. And especially now, you need to know if it's MSI. There are few patients who are MSI, but there you can treat them very well with immune checkpoint inhibition. You need a good MRI. You need to know the anatomical extent. Can I achieve an R0 or R1 resection? If you don't think you will be able to achieve a macroscopic complete resection, you don't go ahead with an R2 resection. So it has to be realistic. Then you have to assess the fitness of the patient and decide what the patient wants. If the patient is elderly, you're not going to take on very complicated procedures. So you have to decide, am I going to go for maximal treatment, a younger patient, than you do? And if you're adding other neoadjuvant treatments, you sequence the treatment and you schedule the surgery last, because sometimes if you give neoadjuvant therapy, they may develop metastasis, and then you can avoid futile major surgery. This is a case which is clearly inoperable. It is high sacral involvement. It's growing in the sacrum. It's in S1. So in this case, even if it's a young, fit patient, you give radiotherapy or systemic therapy, but no surgery. How can you improve local control? Why the resections? A Dutch Scandinavian study compared 2 large volume hospitals. They had a different strategy. In Karolinska, they were highly selective with neoadjuvant therapy, but they relied on very extensive resections, bony resections, exenterations. They had a high R0 percentage. In a Dutch hospital in Eindhoven, they relied much more on neoadjuvant therapy and intraoperative radiotherapy, and they did less extensive resections. They had a worse R0 resection rate. And you would think that the Dutch series was gonna be worse off. And indeed, the Scandinavians is the blue line. They had a higher local control in very comparable patients, but the survival was not different. If anything, the Dutch patients with the less extensive resection were doing at least as good. So this means that it is, yes, surgery is important and technique is important, but at a certain point, doing wider resections is futile, and it's biology who determines outcome. So even wider resections are probably not going to do the trick. Neoadjuvant therapy, adding again radiotherapy, that might help. Patients who are not been radiated before, you can give them a full course, of course, but we use re-irradiation 30 gray a lot, and we use intraoperative radiotherapy also. This makes sense to improve local control, but there are some toxicity concerns of higher doses. There's no solid evidence that it works, but we rely on that a lot. What else can you do to improve local control? That's systemic therapy, but I will just mention this French GRECAR 15 trial. They are evaluating the value of re-chemoradiation or not in recurrent rectal cancer. It makes sense to add systemic therapy because most of the patients are dying from metastasis. And again, there are cohort studies suggesting a positive effect. And if you have a PCR, which occurs, you're doing really well. But again, that's biology. If you're looking at the survival curves of two cohorts from the Eindhoven group in the Netherlands, we're not sure if that really improves survival, although we hope it does. And for this, we are running also a trial for locally recurrent rectal cancer, where we give radiotherapy and re-irradiation standard in both groups, but we're adding induction chemotherapy upfront to see if that is going to make any difference. Now, for the surgical part, the ingredients for good surgery are sound anatomical knowledge, excellent imaging. MR imaging is indispensable, and you need an experienced team. In the Netherlands, it is centralized, and I think this type of surgery should be centralized. You need a reconstructive surgeon, urologist, a good anesthesiologist, ICU people. We schedule one patient for a day because you need to you cannot do this pushed for time. You need time to do this, and we have intraoperative radiotherapy facilities, which we think helps. Here is an example. We have the intraoperative brachytherapy thing. That's the one up front in Eindhoven, and other series, they have intraoperative radiotherapy. Again, not proven, but we seem to get as good results than with some less extensive surgery. What we already did for a long time was we had the MRI ready in the operating room, and we were basing our operations on the MRI on the screen, but nowadays we are doing intraoperative MR-guided navigation. We've developed this, and especially in these fibrosed, irradiated areas, it helps you to tell you where the bone is, where the resection margin should be, where the nerves are. So this we find very helpful. This is an example of a presacral recurrence where you could decide to scrape it off the bone and then apply intraoperative radiotherapy, or you could decide to do a sacral resection, which is a more procedure with more morbidity. Generally, you don't do it at S1 level, S2, below S2 for certain, or through S2 you can do that too. Of course, you're going to damage a lot of nerves, and you can see the bladder catheter here because the bladder is no longer functional. This is a case where it was involving the perineum and the ischiosacral bone. You can decide to take it off, and you need a good plastic surgeon to fill that. Otherwise, you're going to have infectious complications. These are the more difficult procedures: lateral pelvic sidewall. You can see the internal iliac. You can just resect those together with en bloc with the lateral recurrence, and you expose the lumbosacral nerve roots. That's the yellow arrow here. Sometimes you have to go deeper and you have to expose the whole lumbosacral nerve roots, and sometimes even deeper, where you have to resect the nerve root L5. You can resect the whole vein. You don't have to reconstruct it. You get a swollen leg, but that goes away. And this is the pelvic side bone. We rarely resect the pelvic side bone. We put intraoperative radiotherapy there. You can resect vessels, but when the internal iliacs, you don't have to reconstruct. External iliac vein, you don't have to reconstruct either, but the artery is different. This was a very high local recurrence that was involving the vessels. This was at the end the reconstruction. You can be very creative here. So we resected the whole common and external and internal venous axis on the left side. We resected the common iliac artery and the internal iliac artery on the right side, and then we used a part of the vein from the left side to reconstruct the artery. These are procedures with a lot of morbidity, but in some young patients who are not metastasized, this is worth the effort. You're going to run into trouble if you do this, so you have to take care of your complications too. And the most common are infectious complications, which are better prevented with the use of omentum and muscle flaps. So you need your plastic surgeon, and you have to treat infection aggressively to prevent infectious bleeding. The second most common trouble is urological problems when you reconstructed everything. So our big friend is the W you see there. The outcome, I already mentioned that it resembles metastatic disease, so your overall 5-year survival is going to be somewhere in the area between 20 and 30%. If you can do an R0 resection, it's a little better. If you do neoadjuvant therapy, it might be a little better, but we're going to address this in our randomized trials. This is work from the Pelvics Collaborative Group. One last case I will show you. This is a patient who had a quite large presacral recurrence. He was previously unirradiated. We started with induction chemotherapy, then a full course of radiotherapy. And then he seemed to have a complete response. And rather than go ahead with a very large resection, we decided with the patient to watch and wait. We closed his ileostomy, created an end colostomy, and so far we're more than 5 years out. There's still no evidence of disease. So also in these patients, you don't see it very often, but when you see a complete response on MRI, you might consider watch and wait. So I'd like to conclude that I would say before you embark on treating this, you have to think carefully. But then if you decide to go for it, you have to go for it really well. Understand the disease. You have to assess the extent what you're dealing with. And then if you're going to go for it, you're probably going to need neoadjuvant therapy, systemic therapy, re-irradiation, and it's teamwork. You need to centralize this. And you have to learn from it, study it, and above all, it's best to prevent recurrences by doing it proper the first time. Thank you for your attention.
Thank you so much, a very difficult part of the rectal surgery, of course, very dramatic surgery. And we very appreciate all the data and great experience, very presentable clinical cases. I also want to be thankful for European Society of Surgical Oncology for support of Ukrainian surgeons. For now, it's free of charge for us to be the members, and I want to emphasize this. We don't have, if we have any question from board, no? Then thank you so much to be with us, and we will continuing. For now, I will present Vitaliy Poylin with a lecture because we don't have a speaker.
Okay. Thank you, everybody, very much for this invitation. I'm humbled to be able to give a presentation this morning on the management of peritoneal carcinomatosis. So one of the surgeons that was a prominent figure at the institution where I trained once said in an address to the Society of Surgical Oncology in the United States that biology is king, selection of cases is queen, and the technical details of surgical procedures are the princes and princesses of the realm who frequently try to overthrow the powerful forces of the king or queen, usually to no long-term avail, although with some apparent temporary victories. And this is an important thing to remember when we think about the management of peritoneal carcinomatosis. Some things for definition to begin. This is a slide illustrating peritoneal carcinomatosis index, which is something that can be calculated either with laparoscopy or laparotomy. We know that cross-sectional imaging is inadequate in most cases of peritoneal carcinomatosis to really tell us the extent of disease because many of the lesions are below the level of detection. And so this was designed to estimate the degree or severity of disease, with many people believing that once this carcinomatosis index exceeds 18 to 20, that often patients cannot necessarily be helped through surgical intervention. And certainly many studies have shown a strong correlation between a lower carcinomatosis index and longer-term survival. However, probably more important is the cytoreduction score, which is really, despite how much disease may be present, how much of the disease can you effectively remove. And this can range from, are split into two categories of optimal and suboptimal. And we think of R0 and R1 resections and R2 resections in other tumors as being, you know, especially R1 and R2, very suboptimal. But in some cases of cytoreductive surgery, this can actually be still beneficial and helpful. But this is another slide that's important to remember when you're considering the management of peritoneal carcinomatosis from a surgical perspective. So with some background, in the United States, there are about 75,000 patients per year who will develop peritoneal metastases. The peritoneum is the primary site of metastatic disease for patients with carcinomas of the appendix, ovaries, and for those with primary peritoneal tumors such as mesothelioma. And you can see that the overall number of cases, especially with the appendix and primary peritoneal disease, are relatively limited, which precludes a lot of prospective study and much more retrospective and single institution study. By way of further background, these other cancers where cytoreductive surgery and intraperitoneal chemotherapy have been used have much higher rates of hematogenous metastatic disease. And especially in hepatopancreaticobiliary malignancies, the use of cytoreductive surgery and intraperitoneal chemotherapy is very limited because of the very high hematogenous tumor burden and the risk of recurrence widely, which is independent of the peritoneum. Some of these other tumors have shown higher rates of carcinomatosis in the peritoneum, and therefore cytoreductive surgery has been employed in the treatment, and we'll go through some of that later. Colorectal carcinoma, about 20 to 25% of cases will at some point have, with metastatic disease, will at some point have peritoneal involvement, and this is about 20 to 25,000 cases per year in the United States. Gastric cancer is a higher rate, excuse me, of peritoneal involvement, but as it is a less common disease in the United States, only about 8,000 cases per year. I'd like to focus a lot of the time on appendiceal neoplasms, as the concept of cytoreductive surgery and intraperitoneal chemotherapy has best been proven in these types of tumors. These are uncommon, less than 1% of gastrointestinal malignancies, but more than 20% of them can develop peritoneal metastases either at the time of diagnosis or at some point in the future. There has been a lot of shifting nomenclature as the pathologic understanding of these tumors has evolved. And one of the factors which precluded good study of these tumors were that they were not being characterized in a common language that various institutions could use to compare like to like. The most recent iteration breaks this up into 5 different categories. The low-grade mucinous carcinoma peritonei, most commonly thought of as pseudomyxoma peritonei, high-grade mucinous carcinoma, the high-grade mucinous carcinomas with signet ring cells, which typically have a more dire prognosis given the signet ring morphology, and then those with adenocarcinoid or goblet cell adenocarcinomas, which are also biologically more aggressive. Non-mucinous adenocarcinomas, excuse me, are relatively uncommon and treated very similarly to colorectal carcinomas. If we look at appendiceal neoplasms historically, the median survival was very low in the setting of peritoneal metastases without treatment. And some of this data is from the EVOCAPE study, which looked at natural history of disease. And this is mainly because of symptoms such as pain, ascites, intestinal obstruction, and subsequently malnutrition and failure to thrive. And this not only kind of makes patients' quality of life very poor, but makes it very difficult, even if you wanted to give systemic treatment, very difficult for patients to tolerate or complete any reasonable course of this. Additionally, systemic treatment has often shown to be ineffective because of the plasma peritoneal barrier and the mesothelial cells in the capillary layers that prevent good diffusion of chemotherapy into the peritoneal space when delivered intravascularly, as well as the low cellularity of some of these tumor types, such as the low-grade mucinous tumors, where the cellularity is, there is a paucity of tumor cells, and therefore chemotherapy doesn't work quite as well. It was thought that since symptoms were a main issue in the treatment of these patients, that if alleviation of these symptoms surgically could be achieved, that patients might have improved survival. Debulking surgery was thought of as early as the 1930s. It was often incomplete, and it did improve some symptoms, but patients often had multiple repeated laparotomies, each with increasing risk due to fibrosis and scar tissue and other things leading to intestinal injury and fistula formation. Complete cytoreduction was thought of in a more complete way in the 1960s, and it was seen even then without other treatments that the amount of residual disease and survival were closely related, which goes back to the cytoreduction score that we saw in one of the earlier slides and how important that has remained as a factor. Intraperitoneal chemotherapy was derived as a concept in order to overcome the plasma peritoneal barrier and to achieve higher and more prolonged concentrations in the peritoneum than could be achieved with systemic administration of chemotherapy. This was initially done with 5-fluorouracil, as this was the common treatment at the time. And then the concept of hyperthermic therapy was first devised because it was felt that tumor cells could not withstand the prolonged temperatures that normal mammalian cells can tolerate. Normal cells can tolerate this 41 to 43 degrees centigrade for a much longer period of time than tumor cells. And the first delivery system was actually used in 1980, and this was done with mitomycin C. And multiple studies, both in vivo and ex vivo studies with organoid models, have shown that there is a depth of penetration of approximately 5 to 8 millimeters for intraperitoneal chemotherapy, which again fits with the amount of cytoreduction that needs to be achieved when you're doing your cytoreductive portion of the operation. So low-grade mucinous tumors shown typically little effect with systemic chemotherapy, as mentioned before. And in the United States, cytoreductive surgery plus HIPEC is the standard of care. Typically, the intraperitoneal chemotherapy is delivered for 90 to 120 minutes at 40 to 42 degrees centigrade. There is not a lot of consensus on chemotherapy or duration, but as we'll see on later slides, oxaliplatin has shown itself to be relatively ineffective in general, and so mitomycin C has shown better results across studies around the world. If you look at 5-year survival with a single operation, this can reach as high as 85%, and 10-year survival, not necessarily with a single operation, but most commonly can be as high as 50 or 60%. Recurrence rates of peritoneal disease in these patients range between 26 and 45%. There's really one major study, and you say major study, not very many patients, but enough patients to look at. And this showed that the 5-year survival is actually very similar, but this was with 3 or more laparotomies per patient, with continued debulking at each laparotomy, and each laparotomy showing higher rates of disease and higher rates of complication. As you can see, the recurrence rate of peritoneal disease in these patients is upwards of 90%. And while the 5-year survival was similar, the 10-year survival is much poorer in this group of patients where HIPEC was not used. High-grade tumors differ a little bit because of their tumor biology. There is some responsiveness to systemic chemotherapy. This is despite the plasma peritoneal barrier. Theoretically, these are higher grade and more cellular, and therefore potentially more responsive to chemotherapy. And the standard regimens that we have seen used for the modern treatment of colorectal carcinoma, such as FOLFOX and FOLFIRI, have been mainstays. Cytoreductive surgery with HIPEC in these tumors is also the standard of care in the United States. And timing or ordering of therapy really depends on extent of disease. Many of these patients, because these tumors are known to be biologically more aggressive, will undergo diagnostic laparoscopy and calculation of a peritoneal carcinomatosis index. In these patients that have perhaps a low tumor burden, some centers will proceed with cytoreduction and HIPEC at the outset of treatment and give systemic chemotherapy in an adjuvant fashion. Bulkier disease, often patients will receive neoadjuvant treatment after calculation of the carcinomatosis index with a repeat laparoscopy to see if they are a candidate for cytoreductive surgery and HIPEC. And again, optimal cytoreduction in the category of the CC0 or 1 can achieve a 5-year survival of 40 to 60%, even in these higher grade neoplasms. When we add the signet ring cell morphology or the adenocarcinoid tumors, these have an even greater aggressiveness in terms of their tumor biology. This can benefit, patients can benefit from cytoreductive surgery and HIPEC in select cases, but once again, patient selection becomes very, very important in this situation. And most centers will begin treatment with neoadjuvant chemotherapy to make sure that there is some durability in terms of the stability of the patient or perhaps response of the patient before embarking on a morbid operation like cytoreduction with HIPEC. And you can see here that in a single center retrospective view, 76% 3-year survival with cytoreduction and HIPEC, as opposed to 20% without, but again, a highly selected patient population that has done relatively well with systemic chemotherapy. Moving on to colorectal cancer, this is the 3rd most common cancer in the United States and the 2nd most common reason for cancer death in the United States. About 25,000 cases of metastatic colorectal cancer per year will have peritoneal metastases, and about 1/5 of these, the peritoneal disease will be synchronous at the time of diagnosis with the primary. So this accounts for 20 to 25% of stage 4 disease. And certain risk factors may predispose a patient to peritoneal metastases, such as having a T4 tumor, a mucinous histology, or perforation of the tumor. Again, harking back to the EvoCape study, which looked at natural history of disease, the 5-year survival untreated is a median of 5.2 months. And this is often due to factors which are secondary to the peritoneal studding, such as bowel obstructions, ascites, pain, and subsequent malnutrition and failure to thrive, just like we see for the appendiceal neoplasms. The systemic therapy, the modern systemic therapy that is used and has been found to be very effective for lymph node positive disease or stage 4 disease is not as effective in these patients. And part of it is that these chemotherapy regimens are not necessarily easy for patients to tolerate, and the severity of the symptoms preclude completing many cycles of chemotherapy and almost always preclude completion of an entire course of chemotherapy in many of these patients. The median survival, you can see, is 30 to 50% less for patients with peritoneal involvement than for other stage 4 patients. A study from the Netherlands in 2003 demonstrated or compared the use of systemic 5-fluorouracil and palliative methods versus 5-fluorouracil and cytoreductive surgery and HIPEC done with mitomycin C. This was just over 100 patients and showed a significant difference in the median survival, almost twice as long in the patients who underwent cytoreductive surgery and HIPEC. And you can see here that the most important independent predictive factor of whether patients did well was the completeness of the cytoreduction. So if you could achieve R0 disease, you actually had quite excellent median survival and 5-year survival for stage 4 disease, whereas this dropped off significantly as the quality of the cytoreduction decreased. So this has led to the establishment of using cytoreductive surgery and HIPEC when it's believed that you can achieve optimal cytoreduction. Because it is a relatively morbid procedure for patients to undergo and requires strict patient selection, you really have to make sure that when you're looking at these patients and evaluating them preoperatively, that they are patients that you're likely to benefit and not patients that are going to just be put through a big operation. And specialized training, which has evolved in the United States and around the world over the past several years, has led, just like in tumors of the pancreas and liver, lower morbidity and mortality and higher proficiency of surgeons to be able to achieve these improved cytoreductions. We'll see in the next slide, but paradigms of treatment differ around the world. In the United States, for current treatment for colorectal carcinoma with appropriate degrees of peritoneal metastases are systemic therapy combined with cytoreduction and HIPEC. In France, there's a large study that did not show benefit of adding HIPEC, and therefore they use best systemic therapy and cytoreductive surgery. And in the Netherlands, it's cytoreductive surgery and HIPEC without systemic chemotherapy, though that's something that they are further studying at this time. The PRODIGE 7 study out of France, published in 2021, looked at 265 patients, and they tested the efficacy of oxaliplatin as their intraperitoneal chemotherapeutic agent for 30 minutes at a temperature of 40 to 42 degrees centigrade. And these were in patients who they were able to achieve an optimal cytoreduction. Now, interestingly, this showed a 42-month median survival using the best systemic chemotherapy, but they found no benefit to using the intraperitoneal chemotherapy. Some of the theories regarding this is that organoid models derived from patients' peritoneal metastases from tissue banks have shown that oxaliplatin has actually a relatively lower activity in the peritoneal space, and that there are other studies that show that at least 60 minutes of hyperthermia are necessary in order to start achieving tumoricidal benefit. And so these may explain why there was no added benefit to the heated intraperitoneal chemotherapy, but the subsequent study to evaluate this has not been done. And additionally, mitomycin C has not been evaluated in this setting. There is a trial in the Netherlands currently underway, which is evaluating systemic chemotherapy plus cytoreduction and HIPEC versus cytoreduction and HIPEC alone. And this will use mitomycin C. However, systemic chemotherapy is not in the comparison arm, as this is not part of the standard of care in the Netherlands at this point. So it may not really answer the question since HIPEC is being used in both arms. There has been thought of using HIPEC in a prophylactic fashion. And when patients are known to have T4 disease, are seen to have perforation on their initial surgical intervention, or potentially limited peritoneal deposits or metastases, to see if treating those patients early with intraperitoneal chemotherapy may have some benefit. 2 randomized controlled trials using oxaliplatin for 30 minutes did not demonstrate a benefit, but this is not necessarily a surprise given the results of PRODIGE 7. And there are now randomized controlled trials with mitomycin C where there will be longer periods of hyperthermia. Gastric cancer is the 4th leading cause of cancer death worldwide. We see peritoneal metastases in a high percentage of these patients. And again, we have the same issues with systemic therapy because of symptoms created by carcinomatosis. The National Comprehensive Cancer Network in the United States recommends systemic chemotherapy or supportive care in patients with stage 4 gastric cancers who have peritoneal disease. And gastric cancer is a little bit different than the other cancers that we've talked about because often diagnostic laparoscopy is performed at the outset, and positive peritoneal washings are thought to be a predictor of systemic or stage 4 disease, even when overt metastatic disease is not apparent. So there have been some studies to look at whether or not cytoreductive surgery and HIPEC can be beneficial in these patients. Most of them are small numbers of patients, and these are very highly selected with low peritoneal carcinomatosis index and in patients where completeness of cytoreduction can really be achieved well. You see the difference in median survival in this group of patients, but again, very limited study. A larger study from China used HIPEC with mitomycin C and demonstrated a median survival of 11 months with the addition of HIPEC versus 6.5 months with cytoreductive surgery alone. But multivariate analysis shows again that the degree of cytoreduction is really the strongest predictor. And actually the strongest predictor of prolonged survival was the ability to tolerate chemotherapy systemically for longer than 6 months. Retrospective French data, again with very highly selected patients, does so show some benefit to HIPEC in these patients. And thinking about the idea of positive peritoneal washings and this being predictive of stage 4 disease, there has been some work to look at neoadjuvant laparoscopic delivery of intraperitoneal chemotherapy. And this has actually shown to convert patients with positive cytologic washings to negative cytologic washings in a fairly high percentage of patients. And in those patients, again, who are able to tolerate systemic chemotherapy and don't progress after this neoadjuvant intraperitoneal chemotherapy, a certain percentage can go on to definitive surgical therapy with longer median survival. And this neoadjuvant intraperitoneal systemic chemotherapy currently being looked at, intraperitoneal docetaxel and cisplatin delivered 3 times per month for 2 cycles. And you can see here that the positive cytology was converted to negative in 50% of patients, and 70% of those patients ended up undergoing successful cytoreduction. There is relatively higher morbidity and mortality associated with these operations, so again, careful patient selection is important. I think I've gone a little bit over my time, so future directions. More study necessary in colorectal and gastric cancer. This has traditionally been a single intervention treatment, but clearly some patients with longer term survival who have recurrent disease may benefit from repeat treatment, again, depending on the degree of recurrence and the carcinomatosis index and the ability to achieve optimal cytoreduction. Improved understanding of tumor behavior and biology for patient selection. We know that some of the higher grade appendiceal neoplasms certainly are less or more refractory to these types of tumors, but as we better understand what predicts more aggressive tumor behavior, patient selection can be improved, and patient selection has been repeatedly shown to be very important in the success of this treatment. 2-stage procedures for bulky disease. I didn't talk about primary peritoneal mesothelioma. But there are patients who present with bulky disease on the initial laparoscopy when peritoneal carcinomatosis index is calculated, and the leaving of catheters and delivering intraperitoneal chemotherapy on the day 1, 8, and 15 cycle for a couple of months, and then reevaluating to see if there has been a downstaging of the carcinomatosis index is certainly something that is being considered. We talked about the neoadjuvant use of HIPEC, and then the pressurized intraperitoneal aerosolized chemotherapy is currently being studied for efficacy, with the concept that pressurization of the chemotherapy may improve the depth of penetration beyond the 5 to 8 millimeters that is available with mostly passive and not very aggressive kind of motion of the agent in the peritoneal cavity. Thank you, and I'm happy to answer any questions if people have any, or if I haven't gone too far over my time.
Thank you so much. We appreciate the job you did for. We liked your presentation so much, and we also appreciate for your showing to us the changing of the paradigm of treatment of patients with carcinomatosis. So we are waiting for the results of the future trials, especially with colorectal cancer and gastric cancer. So thank you so much. Можливо, в когось є запитання? So we don't have questions. Thank you one more time. Appreciate your participation and your time. Thank you. І наступна доповідь ми запрошуємо учасника. We invite Ryan Merkow with topic regional treatment for colorectal metastasis, role of hepatic pumps. Він є у нас на зв'язку? Ага, окей.
Hello, good afternoon, everybody. It's morning time here in Chicago. I apologize for not being there in person, but I hope everyone is well. I'm really happy to join you all today to talk about the role of hepatic artery infusion pump chemotherapy. Although this therapy is used for other cancers other than metastatic colorectal cancer, by far the primary indication, and 95+% of patients who are using this therapy is in metastatic colorectal cancer. So I'm going to focus on that for my talk. If at any point in time there's questions, feel free to interrupt, and hopefully there's time for questions at the end. So let's see here. There we go. So my agenda is brief and straightforward. I'm going to talk a little bit about the rationale of the therapy, just to introduce it, as I think it may be something relatively new to some folks. Talk a little bit about the safety of the therapy, and then get into some of the evidence, both in terms of using it in the adjuvant setting and the unresectable setting, which I'll explain shortly. So as you all know very well, metastatic colorectal cancer is a major public health issue worldwide. In the United States, at least, it's the third most common malignancy diagnosed. Over 150,000 new colorectal cancer patients are diagnosed each year. Unfortunately, 25% of patients have liver metastases at the time of diagnosis. And among those that are initially present with non-metastatic disease, 50% will develop liver mets during follow-up. And among those who have liver mets that are completely resected or addressed with other techniques like ablation, 50 to 75% of those patients will recur in the liver after resection. And among these patients, this phenotype of liver-only or liver-dominant metastatic colorectal cancer, the most common cause of death is what is happening in the liver. So complete resection is really the only hope for cure for these patients. And therefore, liver-directed therapies that maximize the response in the liver, minimize recurrence in the liver, and/or lead to complete resection are really fundamental goals of therapy. And that is where hepatic artery infusion pump chemotherapy comes in. This is of course, a regional therapy, which is defined as delivery of a cancer therapy to a specific organ, a compartment, or a body region to maximize treatment where it is needed most, sparing unaffected regions or tissues in the body. And this is exactly what HAI therapy does. And I'll explain a little bit more in the next several slides. The rationale of this therapy is straightforward. Liver metastases are perfused by the hepatic artery. As you all know, there's two blood flows to the liver, portal venous flow as well as hepatic arterial flow. Metastases are fed by the arterial flow. So any delivery of therapy through the artery will target these metastases specifically. Some agents that we use can be completely extracted in the liver on first pass metabolism, limiting their systemic toxicity. And that is where the chemotherapy that we use for HAI fits in very nicely. It's FUDR, or fluoxuridine. This is a very old chemotherapy. It's been around for a very long time. And what makes it not a good systemic chemotherapy, we actually leverage that as an HAI to make it actually a very ideal therapy for intra-arterial delivery. The half-life is very short. And so it enters the liver, gets completely metabolized, and does not exit the liver. And because of that property, we can really dial up the concentrations of this chemotherapy and get concentrations 100 to 400 times what the liver would normally see if we deliver this therapy through the systemic circulation or IV. And so we take advantage of that property for HAI therapy. This is what the hepatic pump looks like. It's the size of a hockey puck. You can see the catheter that is coming off of the pump itself. Is placed in a subcutaneous pocket, usually in the left abdominal wall, but it can really go anywhere. This is very similar to what you would essentially see with a Metaport. The concept is identical. However, unlike a Metaport, the hepatic pump has a reservoir which holds 30 milliliters of fluid, and so we can put chemotherapy in that reservoir, and it gets slowly delivered into the hepatic artery and then into the liver. The catheter itself is placed usually in a major side branch of the hepatic artery, the gastroduodenal artery, and importantly, the surrounding tissues are cleared from the hepatic artery and GDA. Small little lymphatics and small arterial branches to ensure that none of the chemotherapy that is delivered through this catheter escapes and gets to surrounding tissues and organs like the duodenum, pancreas, and the stomach. This is what the pump looks like in reality. You can see that you can see the midline incision here and the subcutaneous pocket just on the left side here. It's essentially secured just like a Metaport is secured to the underlying fascia, and then the pump pocket gets closed in layers. This is just a screenshot of an actual catheter in the GDA. You can see the hepatic artery is here going up towards the liver. This is the GDA, and bile duct and portal vein are underneath. And this catheter is secured with several sutures. There's actually there's little beads on the catheter itself, which helps secure it in place so the catheter doesn't slip and fall out of the artery, which of course would be not a pleasant complication to manage. In terms of the complications, this study was actually, it's fairly old now, but I think it holds up quite well. This is looking at some of the HAI specific complications. And overall, the big picture here is that the pump itself is actually very safe. There's rarely some issues that can arise, like anytime we're manipulating or operating on any structure or body part. You can get dissections or thromboses of the hepatic artery. Fortunately, that's extremely uncommon. You can have issues like pseudoaneurysm, again, uncommon. Probably the most important complication that I get concerned about is biliary toxicity or biliary sclerosis, where the bile duct actually can get damaged or injured because of the intraarterial chemotherapy being delivered, which is biliary toxic. It's not so much hepatocyte toxic, but it can injure the bile ducts and cause really in some cases a pretty dramatic injury to the biliary tree. Fortunately, that happens between it's low, it's uncommon, but it still occurs. 5 to 10% of patients will experience that complication. In terms of the added risk of putting an hepatic artery infusion pump in, we looked at this a year or two ago, and I think the key concept here is that when we're putting in these hepatic artery infusion pumps, we're doing it at the same time as other procedures. We're doing major and minor liver resections. We're taking out the primary tumors, and although it does add some time to the operation, usually an extra 2 or 3 hours to the operation sometimes, it really does not add risk to the operation. The risk of the operation in terms of short-term complications is really driven by what else you're doing at the same time as the resection. It does add a little bit to length of stay in some cases, but that is primarily driven by the fact that we have to do an extra study before patients go home to make sure the pump is working, and so that can sometimes add a little bit of time to their hospital stay. So the two main goals for HAI therapy, when we're talking about metastatic colorectal cancer, and again, this can be used for other malignancies, namely intrahepatic cholangiocarcinoma, at least in the United States. Some people are using it for HCCs in other places, but again, just focusing on metastatic colorectal cancer, the two main settings that we're using this therapy is in the adjuvant setting, meaning after complete resection of all liver metastases, with the goals of decreasing hepatic recurrence. Remember that 50 to 75% of these patients will recur in the liver, and so the approach here is to decrease the likelihood of recurrence. Concept is identical to chemotherapy in stage 3 colon cancer, in hopes of improving survival. And then the other main setting is in patients that are unresectable, whether biologically unresectable or technically unresectable. These definitions are important and can be argued and discussed at length, but essentially it is a situation where you can't go to the operating room and completely remove all disease in the liver. And so the goal here is to convert the patient from unresectable to resectable in a staged fashion. And commonly what we will do is go in, put a pump in, clear the future liver remnant, and oftentimes take out the primary if the primary is still in place, and then come back as a second stage after 4 to 6 months to completely clear all disease in the liver, with the underlying goals here of improving survival. There is a concept of destination therapy or bridging to other therapies. This is getting into the weeds a little bit, but there's some folks that are unresectable, and it's very challenging to see any pathway to complete resection. And many of these patients have sort of gone through their all the different lines of chemotherapy, and they're either resistant or they're progressing. And so we'll sometimes use this treatment in that setting. It's just a sort of another line of chemotherapy, or trying to bridge a patient to another therapy, such as transplantation. The main concept here is that, like all of our complex decisions for GI cancers, patient selection is absolutely paramount, and HAI should really be evaluated by an experienced team that can place this therapy in the context of all the other tools that we're fortunate to have available, like other intraarterial therapies, interventional therapies, transplantation, and other things that we're doing to make sure we're not burning any bridges and appropriately managing these patients. So let's jump into a little bit of the evidence for this therapy. I've separated this into really two main groups. First, talking about the adjuvant setting. Again, these are folks where you've completely removed all disease in the liver and the pump is there to reduce recurrence. And then we'll move into the unresectable setting. There's really one main phase 3 trial using this in the adjuvant setting. And this was performed by Kemeny et al. And published in the New England Journal quite a while ago. And what the group did was randomize 156 patients who underwent complete hepatic resection. Most of these patients were pre-treated with chemotherapy. And the intervention was hepatic artery infusion pump chemotherapy with fluoxetine, with, at that time, the systemic therapy available was 5-FU and leucovorin for 6 cycles versus just systemic chemotherapy. And their primary outcome was progression-free survival. And this study was powered to detect a 20% difference. Some of their secondary outcomes that they looked at was overall survival, hepatic progression-free survival. And this is the Kaplan-Meier curve from the original publication. And they found a median progression-free survival was significantly improved in the HAI group, 30 months versus 17 months. Median hepatic progression-free survival actually was not reached in the HAI group and was 32 months in the systemic chemotherapy group. So this had a big impact at that time. The subsequent study where they looked at median overall survival actually was not significant in this report from 2005. It's a follow-up. However, there's a indication here that there's likely a difference between these two groups with a median overall survival of almost 70 months versus 60 months for the systemic only group of patients. So there was a lot of debate about how that study and fits into modern therapy and what the role of modern HAI therapy should be. And this observational study, I think, had a relatively big impact nationally in the United States, at least in terms of influencing the role of HAI in the adjuvant setting. It is an observational study. It's not a randomized study, but essentially Memorial Sloan Kettering Cancer Center, which is sort of the mecca for this therapy, looked at their history of all of their patients, both their historic patients as well as patients treated in the modern, with modern systemic chemotherapy agents. So over 2,000 patients. They have a kind of an interesting natural experiment there where one of their medical oncologists, who's been there for many, many years, typically would not treat patients with HAI. And so it led to sort of a nice natural experiment. The outcomes the study looked at included overall survival, median overall survival in the modern era, which they showed a significant improvement, 72 months versus 51 months, and then 38% versus 24%. We don't have time to kind of get into the details of this study, but they sort of did a number of subgroup analyses and found that actually patients that had the lowest Fong scores or the lowest risk lesions actually did much better, but all patients essentially improved with HAI versus no HAI. In terms of the unresectable setting, there's significantly more data here. This is a much more common use of HAI in the United States. There is a phase 3 study which was published in the early 2000s. This is a multi-center study where they looked at HAI alone versus systemic chemotherapy. They randomized 135 patients from 9 centers. The enrollment was from 1996 to 2000, so again a little bit older. The intervention here was HAI without systemic chemotherapy. It's a little bit different than what we do currently. And the control arm was systemic chemotherapy alone. And of note, this is a dated study, but in the later years of this study, they did introduce or allowed the use of modern chemotherapy if there was progression. The outcomes that were looked at included overall survival, response rate, hepatic disease-free survival, as well as quality of life. And what they found here was an overall survival benefit, 24 months versus 20 months, a 2-year benefit in terms of median survival, 51% versus 35%, and a significantly improved objective response rate. You can see the numbers, almost 50% versus 25%. Time to hepatic progression was improved in the HAI group. Time to extrahepatic progression was actually significantly worse in the HAI group. Remember, that group did not get any systemic chemotherapy, so that's not really a surprise that they had extrahepatic progression. And quality of life was improved at every time point in the HAI group. Again, because they didn't get systemic chemotherapy in part, and patients really didn't have any systemic side effects from the HAI. This is just an example of one of the patients included in the study. Obviously, this patient has a significant burden of metastatic disease, and fortunately was able to be converted to complete resection. The next study I wanted to talk about was a modern study. This was a phase 2 trial out of Memorial Sloan Kettering, where they looked at 49 patients with unresectable hepatic-only metastatic colorectal cancer. These patients were heavily treated with systemic chemotherapy. Most were on second or third line chemotherapy, actually. The median number of tumors was 14. So these are patients with significant burden of disease. And they looked at outcomes after HAI therapy in the modern time period. So with modern systemic chemotherapy agents. And the primary outcome was a conversion to resection. Of note, this was an important study for a number of reasons, but one of the reasons was initially they used bevacizumab and found that patients had significant biliary toxicity with this drug. And so it was dropped from the study, and it is now contraindicated for patients who are actively getting HAI therapy. They can get it before HAI or after HAI, but they definitely cannot get bevacizumab during HAI therapy. So what this study found was they were able to convert 52% of patients. Again, we can debate about the definition of resectability, biologically unresectable or technically unresectable, but they were able to convert over half of the patients. The median overall survival was 46 months. In the chemo naive, it was almost 80 months. Previously treated, it was 30 months. And 14% of patients were, quote, cured 8 of 9 in the resection group. So clearly, if you can get folks to complete resection, they will do significantly better than patients you can't get to complete resection. This is one of their follow-up studies looking at a landmark overall survival analysis, indicating that at 1 year, if you can get patients to resection, you will not reach median survival. The patients do significantly better than those who are unable to be converted by one year. There's a number of observational studies, both at Memorial and outside of Memorial, that have looked at different subgroups of this advanced population. This is a group of patients that were completely resistant to basically all chemotherapy. Very tough group, but they had liver dominant disease. Some had some extrahepatic disease, but the burden of disease was minimal, and found that there was a significant response rate. Over a third of patients did have a response to this therapy, and overall survival was 17 months in the liver-only group and 9 months in the liver-dominant group. So they had extrahepatic disease, which indicated at least there's some indication in these very, very challenging patients using HAI therapy. Outside of Memorial, this study done at University of Pittsburgh, they looked at their experience with unresectable patients. These are patients who were technically unresectable, so they left out the biologically unresectable patients. No extrahepatic disease. This was they only include patients that were treated with modern chemotherapy agents, 86 patients. The groups were relatively balanced, although there was more transarterial radioembolization within the systemic group, which is not a surprise. Conversion was actually about 13% in the HAI group versus about 7.5% in the systemic only group, which is a little bit lower than what the Memorial group published, likely based on the definition of unresectability or resectability. In terms of outcomes, they found that patients treated with HAI had a significantly improved overall survival with a hazard ratio of 0.39 compared to the systemic only group. So although I'm not at Northwestern anymore, our experience there, we looked at, and this is a publication being published very soon here, but essentially we had actually it was 53 patients by the time I actually left. Over half patients pumps were placed in the adjuvant setting. All patients we were able to initiate HAI therapy with floxuridine, and to date we've converted around 30% of those patients who are initially unresectable. There's another patient or two that we're kind of waiting to see if we'll be able to convert. And at the end of the day, this is obviously a small single center study, but we believe that HAI is safe and feasible both in adjuvant and unresectable settings outside of Memorial Sloan Kettering, which is where most of the data in the world is coming from. And again, this publication is in process. I just wanted to highlight an international HAI consortium. This HAI, we call it the HAI Consortium Research Network. It is a group of institutions from actually around the world. We have some European centers, center in Mexico. We have a center in the Middle East, and essentially it is a group of like-minded individuals that have similar goals in mind, generating multi-center trials. We've created a multi-institutional database to study this therapy in more detail. We provide resources and support for centers that are starting to make sure this is done safely and well. And recently have started quality collaborative using some of the QI techniques to just make sure we're doing this well, safely, and then studying our outcomes and feeding those outcomes back to hospitals so they can see what their performance is. This is just a quick curve demonstrating the exponential growth in this therapy over the last several years. I think a lot of this is probably based on that JCO paper that I showed, but it's hard to know exactly why it's all of a sudden being popularized again. It's been around for many, many years, but it's an exciting time for this therapy. And then finally, I just wanted to highlight a approved trial that is going to start enrollment in the U.S. Shortly, which is attempting to answer the question of the use of HAI in persistently and technically unresectable liver-only metastatic colorectal cancer patients, and randomizing between HAI and systemic chemotherapy alone. So obviously the results of this won't be around for a long time, but we're excited about it, and we hope to answer this question with a modern trial in the next 5 to 10 years. With that, I'll conclude. Again, it was it's my pleasure to be here today. Really an honor to present to everybody. And if there's a question or two, I'm happy to address it.
Dear Ryan, thank you so much for your excellent presentation. We're also HR center in Ukraine. Maybe we can discuss some collaboration in this way. And for us, as for the surgeon, this is the perfect way to do not perform exploration when we have a much more tumor burden in the liver, when we plan to do resection, and then turn it to the placement of catheter rather than do just simple exploration. That means it's a good possible way, and also the good way to break through the chemo-resistant after multiple cycle of chemotherapy. We have one question from the auditor. Yes, please.
Thank you very much for the great talk. And I have a question regarding what is the routine practice for Chicago in putting these pumps? Because here in Ukraine, usually these kind of patients who are out of any options of systemic treatment, so we use it like a last type of therapy. So for patients with liver-only metastasis, and what is routine? What is the average patient for Chicago?
Yeah, that is a great question, and it depends. Different centers will start based on their their comfort level. Usually, in the group of patients that really have no other options, and it's they're either have disease stability or they're progressing on systemic agents. We've experienced that if you can get this therapy in earlier, after getting some understanding of their disease biology with some systemic chemotherapy lead in first, but getting the pumps in a little bit earlier, I think patients actually can do better. So in the unresectable setting, will oftentimes, if they're clearly unresectable, we'll try to get pumps in them after 6 cycles or so of lead-in with systemic chemotherapy, just to have an understanding of that biology, to make sure they're not going to have extrahepatic metastatic disease, and have seen great responses in that setting. In the adjuvant setting, it's pretty similar. There's folks where I have a high degree of confidence that I can go in and clear everything in the liver. However, I do want to make sure that it's biologically appropriate. And so we'll give some systemic chemotherapy for 6 cycles. And then if they're still doing well, then place pumps and clear all disease in those patients. There is some controversy of when you use pumps in the adjuvant setting. And my practice, our group's practice has generally been that if they have 3 or more lesions, we'll clear them and put pumps in. When they have 1 or 2 lesions, I'm not quite sure. The Memorial group would definitely put pumps in those patients, but of course, I worry a lot about the biliary toxicity in those potentially curable patients, and so I'm a little bit hesitant to use it for very, very low volume disease if they just have a single met or 2 mets in the liver that are very easily addressable, addressed with resection or ablation.
One more question.
Thank you so much. You almost answered to my question, but nevertheless, I'm interested about liver toxicity. So the limitation of the liver resection can be liver toxicity due to this intra-arterial chemotherapy. Did you have such cases when your metastases are resectable after the treatment, after intra-arterial chemotherapy, but you cannot perform it due to the toxicity, due to the necessity of performing of wedge resection or big liver resection, something like that? Do you have such problem?
Yeah, good question. The main toxicity that I am very paranoid about with HAI therapy is biliary toxicity, where there's such in the 5 to 10% of patients can get a pretty severe injury to the bile duct, which limits a lot of therapy. It's really challenging if it's an adjuvant pump and you've basically cleared their liver, and some patients are actually cured of this disease, but they're left with the toxicity of biliary sclerosis. That does occur. Fortunately, it's uncommon. We've learned a lot over the last several years of how to minimize that. Unfortunately, we think that there is higher rates of biliary toxicity in the adjuvant group of patients versus the unresectable patients. I can't explain why that occurs, but we see higher rates in that group. And those are the patients that we're, especially hopeful that we can get to cure. So we have, we put in 55 pumps or so in the last 2 years of putting pumps in at Northwestern. We actually saw 0% toxicity for unresectable, but around 10% of biliary toxicity in the adjuvant setting. And so those are patients that are managed with catheters and stents and often do quite well. And there's data to indicate that it doesn't really impact their survival. But occasionally you get a patient who just has very destroyed bile ducts and actually can evolve into cirrhosis and be a cause of death. And there's some patients that would go on to transplant in that setting. Fortunately, is very uncommon, but I have seen it in one patient that I've treated, and then I saw it at Memorial when I was there. It's a big problem, and we need to learn more about how to select and minimize that from occurring in those, especially in those potentially curable patients.
Thank you.
Thank you one more time. Hope to see you later in Kyiv once more. And keep yourself. See you. Thank you.
Thank you. Thank you. Appreciate it.
And we are continuing. The next lecture will be from Northwestern University. Do we have lecturers there? Yes. I'm presenting Robert Lewandowski with a lecture about interventional radiology, the role in the treatment of the liver metastasis. Роль інтервенційної радіології в лікуванні метастазів.
Great. Thank you and good evening. Certainly a pleasure to be here. For those of you disappointed that it's not this Robert Lewandowski, I hope that my talk will suffice. And, in the grand scheme of things, as an interventional radiologist specializing in treating patients with liver cancers, certainly it's a great pleasure to be speaking with my colleagues, my surgeon colleagues in medical oncology and radiation oncology. As a multidiscipline care of our patients is super important and very interesting for all of us, I think. Given the 20-minute time slot, I'm going to really focus my talk on intraarterial therapies, really more specific about radioembolization, as that's what we're known for here in Chicago at Northwestern University. But really, we've sort of evolved this versatile tool to help us treat patients as an adjunct to surgery or other medical oncology or radiation oncology therapies, or as an alternative. So we have a couple of different ways of doing radioembolization, and I want to talk about that today, both in primary and secondary hepatic malignancies. Not to say that ablative technologies are not super important, and those are evolving as well. We certainly have a toolbox. This is a very simplistic diagram, but from an ablative standpoint, we're often talking about those patients with oligometastatic disease, really confined disease, small tumors, limited numbers of tumors in favorable locations, at least if we're going to consider doing it percutaneously. Again, a great technology that many might argue is a good alternative for surgery in some patients. But again, I think working as part of a multidiscipline group, selecting the appropriate patients is very important. When I think about the role of treating liver cancer, whether primary or secondary hepatic malignancies, I have different embolotherapies at my disposal. And just to put it quite bluntly, when we think of embolization, we have either bland or chemoembolization, whether we're emulsifying a drug with Lipidol, creating an oil, a water and oil emulsion, or giving drug-eluting embolic chemoembolization, putting drugs onto beads and delivering them. At the end of the day, those are macroembolic therapies. And what I mean by that is that while the drug may play a role, what we're really doing is achieving ischemia and hypoxia by preventing blood flow to these tumors. We know that in general, when we do these types of therapies, we will upregulate growth factors. And I think that's shown in when we look at, particularly in the hepatocellular carcinoma, where these are all used quite interchangeably at different centers across the world, we see upregulation of growth factors due to that ischemia and hypoxia. Now, posit that radioembolization is a different therapy, and that's because these microspheres are much smaller. You can see here at 20 to 60 micrometer, but usually they're 20 to 30, 35 micrometer. And really now we're using these microspheres as a carrier of an isotope. Currently in the United States and much of the world, that isotope is yttrium-90. So Y90 is how we refer to that. The holmium is now becoming much more commonplace in Europe. Its development in the Netherlands and becoming more widespread, although not currently of use in the United States. But with that, the goal of radioembolization is to deliver a radioisotope, high dose of radiation to the liver, to the tumors in the liver, and not ischemia and hypoxia in general. When we do angiograms, as we completed our delivery of our microspheres, we see preserved blood flow to these tumors. So ischemia and hypoxia is a small part of that. And with that, we see radiation effects 2.5 to 11 millimeters from the beads. So what that means is that this is outpatient therapy. Patients are not quarantined, and patients can carry out their lives and not have to be hospitalized afterwards. And there really is evolving data of this, and I'll show a few studies because a lot of this has been developed in hepatocellular carcinoma at our center, and we're a liver transplant center, as well as a busy surgical oncology and hepatobiliary program. So when we look at the application of radioembolization for hepatocellular carcinoma, this was a prospective randomized trial from our center here, comparing it to conventional chemoembolization. So with Lepidol, for those patients that our tumor board deemed not resectable and not ablatable. Again, maybe beauty's in the eye of the beholder. Different centers have different thresholds for doing these other therapies. But what we found is that the study was positive from a primary endpoint, time to tumor progression, time from treating the tumors to that they progressed. You see with radioembolization over 2 years, time to tumor progression versus 6-7 months for chemoembolization, which is consistent with what we know in the published medical literature. As we think of the endpoint, very difficult and lengthy and cost prohibitive to do some survival analyses, survival endpoints for earlier stage hepatocellular carcinoma. That's not what transplant and resection is based on. But time to tumor progression is important, particularly in these patients that were bridging to liver transplant or downstaging and bridging to liver transplant, allowing these patients to be treated once and maintained on the transplant list. More recently, this paper was published in Radiology in 2022, but it was a European study, again, looking at radioembolization versus chemoembolization. This was drug-eluting bead chemoembolization. This was another prospective randomized trial. And you can see that not only TTP, time to tumor progression, favored significantly radioembolization, but interestingly now in this particular study, median overall survival of these patients, they were not all early stage, but the median overall survival was nearly doubled in those patients receiving radioembolization. So really challenging the role of chemoembolization, which has been the standard intraarterial therapy for hepatocellular carcinoma since 2002, when a couple of prospective randomized trials versus best supportive care supported its use and guideline justification for the BCLC guidelines. But there are a couple of things that I think are really important when we think about radioembolization. I mentioned it's a versatile therapy in terms of where the future of this technology can go. One is in segmental treatments, and I use the word ablative, and I'll talk about why. And the other is in lobar treatments. And I brought the toolbox up earlier, and I didn't include some other concepts. And one I think missing in this particular discussion would be portal vein embolization or liver venous deprivation to promote future liver remnant hypertrophy to facilitate surgical resection in those patients with inadequate liver at baseline. But radioembolization is evolving also as a tool to do that, and I'll talk briefly about that. Now, the concept of doing ablative radioembolization really started back in 2010, at least described as a possibility. And really, it's quite simple. If you can see in this top image, we see a tumor up in the hepatic dome, a small hepatocellular carcinoma. Well, we can see our margins, and this is a cone beam CT or CT angiography done intraprocedurally, and now we have early follow-up. And you can see exactly the radiation changes mirror what we've done in our angiography. We see the tumor within the treated field. Now, these are early term findings, and here you see 4 years later. We don't see the tumor anymore. This is a complete response, and that segment of the liver has scarred down. It's fibrotic. So in essence, we've ablated that segment of the liver, including the tumor within it. Well, how do we decide how to do dosimetry with this? And this is where it's really evolving to understand our complete pathologic necrosis rate, explant pathologic necrosis, CPN, based on patients that have had surgery after segmental radioembolization. These RADPath studies have demonstrated that if we give higher doses, and in this early study, 190 gray was statistically significant to achieve explant CPN. Others have duplicated that. And when we reach that threshold dose, over 80% of the time we have explant CPN. And when we don't achieve that, only a third have explant CPN. And that again is evolving. So now we're seeing if we're giving higher doses to small segments of the liver in selected patients with preserved liver function, Child-Pugh type patients, we can do this safely and we can achieve 100% CPN. Now, nothing is 100%, but that's where it's evolving and really thinking about the concept of maximum tolerated dose. And a lot of centers now are really driving this concept and trying to deliver more definitive radiation segmentectomy for those patients that are not candidates for resection, where the tumors are too big or not in good locations for ablation. With this has evolved, radioembolization is now part of the BCLC guidelines for hepatocellular carcinoma. And that's thanks to this study. It was retrospective and it was multi-center at 3 US sites, but it was looking at patients that had unresectable solitary HCC up to 8 centimeters. You can see the median size was 2.6 centimeters. These were all Child-Pugh patients. But you can see very high response rates, 88% objective response rates. Almost all of those were complete response based on MRECIST. Most patients, 97%, achieved their best response with one treatment. Duration of response over 6 months in 76%. And there was no local tumor progression at 2 years. So the duration of response takes into consideration new tumors developing. So again, a very durable local control therapy with high explant CPN rates. More recently, this was published in Lancet Gastrohepatology from New York, looking at the Child-Pugh B7 patients, solitary HCC up to 3 centimeters. This was a prospective study. And you can see for these small tumors, 100% explant CPN with a median radiation dose to those segments, those small segments of 584 gray. So high doses, again, pushing the dosimetry for this technology done safely. You can see the objective response rate, MRECIST, 100%, mostly complete responses again. And as I said before, the median time to target lesion progression for these small tumors treated with these high doses is not reached. So really pushing the boundaries of this technology as an alternative to thermal ablation. And again, I think it makes sense in those patients that are not good candidates for ablation, either due to tumor size, comorbidities, or tumor location. Just a couple of quick anecdotal cases. This was a patient that I was bridging to liver transplant with segmental radioembolization many years ago. The patient ended up not getting liver transplant. You can see here, 4 years later, very good durable response, no evidence of the tumor. Another patient that also had a history of AML, and the concept was to bridge to liver transplant, but with the history of AML, there was some consideration of whether they'd be a transplant candidate. And here you can see 1 year later, this is a nice response to an intra-arterial therapy, outpatient therapy. This patient lived for a long time with no follow-up. No recurrence at follow-up. And then finally, this was an 18-year-old with cardiogenic cirrhosis and a small hepatocellular carcinoma. And just as a definitive therapy, a little bit challenging to do as a thermal ablation right on the capsule. Certainly can be considered, but just as an intra-arterial therapy, it looks like we've removed that small segment of the liver. This was a patient that now is several years out without recurrence. The other concept I brought up as an alternative to portal vein embolization allows the ability to treat the tumor at the same time of generating that atrophy hypertrophy complex. Very straightforward concept, although the technology and technique is evolving. The lobar radioembolization, you get tumor control treatment of the tumor, you get atrophy of the treated lobe and compensatory hypertrophy of the contralateral lobe. And here's a nice example of a patient with multidysplastic nodules, but in essence, right hepatic lobe HCC. You can see here 1 month and now 3 months after lobar radioembolization, the future liver remnant going from 34 to 69%. The patient had resection. There's a study now that we published 7 years ago in the Journal of Surgical Oncology with my colleagues here at Northwestern, looking at patients out of tumor board that we took that had inadequate future liver remnant. The median time to hypertrophy to have adequate future liver remnant was 40 days. The median time to surgery was 86 days. Again, that biologic test of time, allowing these patients to really self-select which patients are going to benefit most from resection. Moving on to cholangiocarcinoma, as we know, a rare primary liver cancer, but I think there's an evolving role for radioembolization in this. And here you can see just some of the publications, relatively small numbers of patients as, again, a rare type of cancer. Our experience here at Northwestern was published recently of 136 patients that we treated. And you can see most of these patients are relatively advanced central tumor locations, infiltrative morphology, et cetera. But the median overall survival from time of radioembolization, despite these heavily pretreated patient population, advanced patients, was 14.2 months. But I think the really important and interesting concept is to drive more curative intent therapy for these patients and getting these patients to surgery. And here you can see in this, again, this more advanced type patient population, 13% of patients that we saw that had liver-only disease ultimately ended up being resected. And then, interestingly, 2 patients we were able to bridge to liver transplant. Those 2 patients had primary sclerosing cholangitis. So here's a patient with a large infiltrating mass in the right hepatic lobe. We treated biologic test of time, increased the future liver remnant, and the patient underwent a trisegmentectomy and survived 12 years without disease recurrence. Another patient, this was a 38-year-old patient with a PSC. You can see lobar radioembolization, very straightforward. Despite the hypovascular nature of this tumor, not a good candidate for other intraarterial therapies. But with this therapy, we see good tumor control, future liver remnant 34 to 55%, and the patient underwent a resection. Then finally, I brought up that idea of ablative radioembolization, and here you can see this patient with a very infiltrative tumor around the inferior vena cava. This patient underwent an ablative radiation segmentectomy. We were able to deliver a margin around the IVC. We were able to affirm that with intravascular ultrasound, and the patient was ultimately resected. And did quite well. But again, the idea of treating these patients, these advanced patients or these cholangiocarcinoma patients, and getting them to resection or to transplant, I think is a very compelling approach. And this was a study, a phase 2 clinical trial, multi-center European study. And these patients that were treatment naive, and they underwent chemotherapy, first-line chemotherapy, concomitantly with radioembolization. And you can see that the downstage of surgery rate is increasing now to 22%. So the idea of using chemotherapy and radiation or using other local therapies with chemotherapy to drive better outcomes and drive more patients to surgery, I think is an important one. Finally, I'm going to talk about colorectal cancer. And when we think about radioembolization for colorectal cancer, it's typically been in the salvage setting. We've heard from the last discussion about the role of maybe in your center using hepatic artery infusion pumps. We've used radioembolization in that salvage setting. And with that, a lot of evidence early on in the early 2000s, response rates based on size now, not based on necrosis, of 35-40% going up if we look at metabolic response or tumor marker response. And median survival for these patients, again, this is in the salvage setting from radioembolization of 8 to 14.5 months. This sits really well in that salvage setting when we think about salvage chemotherapy and outcomes from salvage chemotherapy. Keep in mind that it's a little bit biased because these are patients maybe not with liver-only disease, but with liver-dominant disease for sure. So it's a different patient population than maybe we think about with some of the systemic therapy trials. But treating patients in the salvage setting, there are some challenges, and one, your therapy keeps getting pushed back, and patients are exposed to more and more therapies. They become sicker. They have more advanced disease by the time they see you. And then there are some potential synergies of chemotherapy and radiation. And we see some early studies that have shown promise combining 5-FU leucovorin, maybe not current chemotherapies, including irinotecan and oxaliplatin, but certainly I think there are some signals that combining these radiosensitizers and radiation makes sense. There was a first-line trial. I'm not going to cover it in the interest of time. That was, in essence, negative for its primary endpoint, trying to integrate radioembolization into first-line with chemotherapy. This more recently is a second-line study. It was called the EPOC study, and it was taking patients that had progressed with liver-only disease and progressed on first-line, and it was randomizing them to second-line chemotherapy, to that second-line chemotherapy with radioembolization. And you can see most of this now was irinotecan based, as the patients tend to in the United States get FOLFOX as first line. I'll point out the dosimetry. This is not based on the personalized or advancing dosimetry that we're starting to see in the United States and now in Europe more commonly. But this study was, in essence, positive. They had co-primary endpoints. One was PFS and the other was hepatic PFS, and both met their endpoints. In this study, the hepatic progression-free survival was 7.2 versus 9.1 months, and the overall progression-free survival was 7.2 versus 8 months. The secondary endpoint of overall survival was not met, and likely many reasons for something like that. Now, just an example of a patient that I treated at our center as part of this trial, as part of the EPOC trial. You can see this patient had post-resection hepatic recurrence, treated and did well and went on chemotherapy as part of this paradigm. They didn't recur till 3 years later, then recurred in their chest with lung nodules and then mediastinal adenopathy. and then had liver recurrence. It was 4 years later that their liver finally recurred. And part of the reason for this, and I think, is the combination of these therapies and also the evolving, again, radiation segmentectomy concept, which has really first described in primary liver cancer. But you can see here now some small cohort of patients in metastatic disease, where now we're trying to parenchymally spare higher dose therapies, getting better tumor outcomes, better tolerability for these patients. And then finally, the idea of future liver remnant hypertrophy, not just in hepatocellular carcinoma, maybe not just in primary liver cancers in general, moving into the metastatic population. And this is a paper published in 2017 from a group in Florida here in the United States. There's 4 patients with metastatic colorectal cancer. All 4 patients went to resection, but it was interesting that 50% or 2 of them progressed after resection at 3 months. Again, bringing up the idea of these patients with bulky disease, maybe higher risk tumor biology, allowing that biologic test of time. It's not just about the hypertrophy, but I think the biologic test of time is important. This is a patient that I treated now several years ago here at Northwestern, really bulky right hepatic lobe tumor and a small lesion in segment 4. FLR was inadequate. We sort of modified the idea of combining systemic and local therapies and treated with FOLFOX and radioembolization. And we got this patient now 6 months later for resection with the future liver remnant of 53%. So with that, I know this was a whirlwind tour and really focused on radioembolization, but it was a pleasure to speak with you. And I hope I stayed within time and people weren't too disappointed that I'm not the professional football player, but happy to answer any questions.
Thank you so much. Very qualified review. We don't have any question? No? Then we very appreciate your time and your participation. Hope you will join to us in our next conference. And maybe some you will visit also Kyiv as participants here in place. Okay, thank you. We'll move further. And our next presentation from Northwest. Do we have speaker? Yeah. Zachary Dietch, about the role of liver transplantation in treatment of primary and metastatic liver diseases. Please.
Hi, everyone. My name is Zach Deitch. I'm an assistant professor of surgery at Northwestern University. And it's my pleasure to be here. My clinical practice principally consists of liver, kidney, and pancreas transplants. So let me work on sharing my screen. Oncology purposes, and I have no disclosures to report. Just a brief outline of my talk. We'll discuss the indications, recipient candidacy, and outcomes for liver transplant in the setting of hepatocellular carcinoma, cholangiocarcinoma, metastatic colorectal cancer, and small series of neuroendocrine tumors. And then I think it's important to touch on, a unique consideration in transplant, which has to do with considerations around organ utilization and organ supply, and how that relates to living donor liver transplant, the use of what we just call marginal organs for transplant, livers from a special category of donors that are not brain dead, DCD donors, and then also split liver transplants. there are some overriding principles around transplant oncology that are kind of unified, despite whatever the recipient's diagnosis may be. So, transplant, the concept of removing an organ and replacing it with a new organ and putting a patient on immunosuppression is fairly unique. And transplant has the potential to cure tumors, eliminate the favorable conditions for cancer progression. So, for example, by eliminating a cirrhotic liver, you are reducing or eliminating the conditions that favor recurrence of HCC, for example. But transplant cannot overcome tumor biology, the stage of a patient's tumor. So, for example, with distant metastases, and transplant can't correct for poor patient selection. So there's been a lot of success, particularly with HCC, but also to limited extent with other disease processes when liver transplant is undertaken in cancer patients with liver restricted tumor burden, and when a patient's tumors have been shown to have favorable response to neoadjuvant treatment. So cancer is a growing indication for liver transplants, and around the world, somewhere around 40 to 50% of candidates on a center's transplant list, so patients awaiting transplant, may have cancer diagnoses. The vast majority of these are obviously hepatocellular carcinoma. And then another thing that you can't escape discussing when it comes to transplant are the ethical considerations around transplant and organ utilization. So in most parts of the world that have active transplant programs, we have to deal with organ scarcity. And so what that means is more patients are awaiting transplant than there are organs available. And this introduces unique ethical considerations. So we have to balance ethical principles of justice and utility, and we have to think about those principles for not just the individual, but also society at large. So, for example, if we're able to achieve excellent outcomes for certain patients with certain disease states awaiting liver transplant, it then becomes difficult to use organs when we know outcomes are going to be suboptimal or not as good for other disease processes. And this is where the challenge of transplant oncology becomes an issue. So certainly here in the United States, where we rely principally on deceased donors as our main source of supply of organs, there are more patients who are awaiting transplant than we have organs available. And obviously this introduces the opportunity for living donation to fill a gap, particularly for oncology patients with cancer who need a transplant. And then the ethical considerations change a little bit when you're thinking about a living donor. You can be perhaps a little bit less restrictive in your selection process for recipients because typically you have a donor who wishes to donate part of their liver to a recipient, and they can have informed consent about the risks and the benefits that they're undertaking. On the other hand, you're now doing an unnecessary operation on a living donor, and you have to balance the donor's interests with the expected outcomes. And so then the question of, well, what's an acceptable expected outcome becomes very difficult, and there's no right answer, and different parts of the world evaluate these differently. And so this diagram here just is from the United Network for Organ Sharing here in the United States that shows patients on the waiting list, annual deaths and of patients on the waiting list and patients who became too sick to undergo transplant every year. And you can see that it's still a fairly large number. So we'll start by talking about hepatocellular carcinoma, which is by far, in a way, the leading indication for liver transplants for patients with cancer. It's a growing indication for liver transplants, and it is considered one of a standard treatment for early stage hepatocellular cancer. So transplant treats the tumor, it treats the underlying disease by removing what is most commonly a cirrhotic and diseased liver. And it's indicated for liver transplant over resection is indicated for candidates who are unsuitable for a low morbidity resectioned or curative ablation. So, patients with significant portal hypertension, or if resection might leave a patient with insufficient hepatic reserve, then liver transplant is indicated. So eligibility criteria for liver transplants are in most parts of the world driven by or the Milan criteria, which were described in the 90s, and these require patients to have a single tumor less than or equal to 5 centimeters, or a total of 3 tumors, all less than 3 centimeters. Now, this doesn't account for tumor biology, and this is simply a size criteria. So, various investigators have challenged these criteria as perhaps too restrictive and have been able to show good or comparable outcomes with less restrictive criteria. So this is a list of some criteria that various investigators have described over the years, and pardon me. You'll see there at the top the Milan criteria, and then in the second highlighted box the survival rates, which is roughly 85% at 4 years, which is excellent and on par with survival rates that we see after liver transplant for other indications. So, for example, NASH, cirrhosis, or hepatitis C. One notable set of criteria, the UCSF criteria, came out of the University of California, San Francisco. So these extended the Milan criteria to single tumors up to 6.5 centimeters, or 3 tumors all less than or equal to 4.5 centimeters, with a total tumor diameter of less than 8 centimeters. And also had fairly excellent outcomes, 81% at 5 years. And then the important thing to note is, as you go down this list, there are different criteria, and the consistent theme is, as one becomes less restrictive in terms of criteria for eligibility for liver transplant, post-transplant survival decreases. And so at the bottom there, if you see, for example, with Kyoto criteria, 65% survival at 5 years is excellent when you think about many cancer operations. But for liver transplant, that's actually, if we had 65% 5-year survival at 5 years, our programs would, here in the United States, would be shut down or put on probation, because we expect much higher outcomes, or much better survival. So, the Milan criteria don't necessarily consider tumor biology, but there are efforts to, or steps in place to consider the role of tumor biology. So, here in the United States, patients listed for transplant with HCC have to wait 6 months before they can get extra points that enhance their candidacy for liver transplant. So we call those exception points. And by getting those exception points, their time to transplant is shortened. Now, over that time, their patients are evaluated for growth, symptomatic progression, vascular invasion, extrahepatic spread. Their alpha fetoproteins or DCPs are followed, And if those show progression or concerning signs, or if someone advances beyond Milan criteria, then they are no longer candidates for liver transplant. So this is one way to account for the tumor biology. And then finally, very commonly, we will use local regional therapy as a bridge to liver transplant or for downstaging purposes. So again, this is, these are maneuvers that allow us to assess tumor biology over time by seeing if patients respond to therapy. These could be ablation or here at my institution, we use radioembolization very commonly. And so for bridging, what that means is we try to control the tumor growth and we reduce the risk of the patient dropping out on the wait list, meaning we reduce the chance that their tumor progresses while they're waiting for exception points or waiting to get to transplant. And downstaging is a way to an attempt to enhance someone's candidacy. So, for example, if they present to us outside of Milan criteria, but say perhaps within UCSF criteria, we can treat their tumors with local regional therapy with the goal of downstaging their tumors to within Milan criteria and make them eligible for transplant. So in terms of outcomes, again, there's no one-size-fits-all approach to what are acceptable outcomes, and that depends, largely on your, the donor shortage, the organ supply. In Asia, this is a much different, expectations are much different than they are here in the United States. The characteristics of the organ supply is much different than it is here in the United States. We don't have a large supply of living donors. We have a large supply of deceased donors, and the converse is true there. And so, the question of what's an acceptable long-term outcome is really one that has to be answered at the community level. But it is generally accepted that we should not be undertaking transplants in generally accepted futile situations. So, for example, when we have extrahepatic disease, it's largely accepted that that's a generally futile situation in which to perform transplant. So I touched a little bit about how organ allocation works here in the United States. It's driven by the MELD score, which I think most folks in the audience are probably familiar with. This is a formula that incorporates PT, bilirubin, creatinine, and the MELD sodium score also incorporates sodium. And then, as I mentioned, for hepatocellular cancer here in the United States, since most patients with HCC still have preserved synthetic function, may not have a lot of portal hypertension, their native MELD scores or their MELD scores may be relatively low, and that presents a challenge to getting transplanted. So the higher your MELD score, the faster you are likely to get organ offers. So to assist patients with hepatocellular cancer who meet candidacy criteria for liver transplant, after a 6-month waiting period, they will get exception points, so points added to their MELD score that is above and beyond their native MELD score, and this shortens the time to transplant. And it's been very successful. So we see tumor recurrence in about 8 to 20% of patients transplanted for HCC. And again, as the selection criteria relaxed, we see higher recurrence rates. And when that happens, when we do see recurrence, it's often extrahepatic and likely due to occult metastases that probably present at the time of transplant. So there have been efforts to identify predictors of recurrence, and there are authors who theorize that there are pre-transplant characteristics as well as such as donor variables. So if we use a marginal organ and have severe ischemia reperfusion injury, there are those who hypothesize that that more severe ischemia reperfusion injury can enhance the risk of recurrence. And then on explant pathology, which obviously is not available at the time of transplant, but once we have the pathology back, we can risk stratify patients for the risk of recurrence based on vascular invasion, the presence of satellite lesions, tumor differentiation, and overall tumor size. For surveillance after liver transplant, there's no strong consensus about modalities and intervals for surveillance, but in general, we see we think about recurrences as early within the first year versus late recurrences, and early recurrences are less than late recurrences, and so for that reason, early on we tend to get cross-sectional imaging, so CT or MRIs every 6 months for 3 years, and then yearly following that. And then most centers will follow AFP levels as well. So in terms of preventing tumor recurrence after liver transplant, there's really a limited role for adjuvant therapy. Has not been much evidence to support that, and that's not commonly done. There are, however, because we put patients on immunosuppression, the most common agent as part of a transplant immunosuppression regimen for most transplant patients is something called within a category of calcineurin inhibitors, so tacrolimus, cyclosporin. However, these come with an increased risk, cancer risk, and so there have been efforts to use another category of drugs called mTOR inhibitors, notably sirolimus and everolimus, as a substitute for calcineurin inhibitors. And these have been shown to have anti-tumoral effects. So this is something that we do here. We do try to do that here at our center, but it is not a universal practice. So we'll move on to cholangiocarcinoma now. So cholangiocarcinoma is a tumor of the bile duct epithelium. 90% tend to be perihilar, about 5 to 10% intrahepatic cholangiocarcinoma. We think about these differently for liver transplant. So obviously for perihilar cholangiocarcinomas, surgical resection with 5-year outcomes are fairly low, 25 to 40% when you think about what outcomes that we see with liver transplant. And then for intrahepatic cholangiocarcinoma, survival depends on the extent of the disease. The incidence here in the States is about 1.2 for 100,000 and tends to be higher in other parts of the world. And historically, this has been an absolute contraindication for liver transplant because of high recurrence rates and very, very low survival rates. So, however, there have been efforts, largely inspired by efforts at the Mayo Clinic, to evaluate liver transplant for perihilar cholangiocarcinoma, and they've shown fairly impressive results, albeit with relatively small patient populations. So up to 65% 5-year disease-free survival. These have been demonstrated in Mayo's initial studies, as well as subsequent studies at additional centers in the United States. And these efforts have allowed us to refine our candidacy around risk factors for dropouts and recurrence. And so we're basically at the point now where to get to receive MELD exception points in the United States, you need to have demonstrated unresectable disease above the cystic duct, a tumor that's less than 3 centimeters in diameter, and that's without intra or extrahepatic metastases. And a candidate has to successfully undergo neoadjuvant therapy without progression of disease. So practically speaking, there are very, very few patients who meet these criteria and ultimately become eligible for liver transplant. So neoadjuvant therapy typically involves external beam radiotherapy with 5-FU and oral capecitabine until transplant. The diagnostic challenges in this disease are significant. So the criteria to establish the diagnosis includes one must have a dominant stricture and one or more of the following: positive cytology by endoscopic brushings, a biopsy-proven cholangiocarcinoma, a positive FISH, or an elevated CA19-9 above 100. Additional technical considerations, because of the possibility for radiation injury and delayed radiation injury to hepatic artery, Mayo in particular advocates for arterial conduits, and these are conduits we can run from the aorta or from the iliac artery using cadaveric vessels, so iliac artery from the cadaveric vessels to provide another arterial inflow, alternative arterial inflow to the transplanted liver. And then, extensive hilar dissection is often a good idea to prevent the potential for tumor spread. And what this may result in is we may end up with a short recipient portal vein. And sometimes this may require an extension using, again, cadaveric venous conduit. And then we should always send a distal bile duct margin intraoperatively to rule out a positive margin. And in the rare circumstance in which that margin is positive, then the patient may be indicated for a pancreatic endarterectomy. So for intrahepatic cholangiocarcinoma, these can arise in cirrhotic and non-cirrhotic patients. And if imaging is not consistent with HCC, then need a biopsy to achieve the diagnosis. Liver resection is the treatment of choice for intrahepatic cholangiocarcinoma. It's feasible. And there are very few indications for, very limited indications for liver transplants for intrahepatic cholangiocarcinoma. This has been done under, close supervision and closely monitored protocols for cirrhotic patients with very early intrahepatic cholangiocarcinomas, tumors less than or equal to 2 centimeters. And these have been done with favorable results, up to 65% 5-year survival. So at this stage, where we are now, liver transplant for this indication should only be offered in the setting of clinical trials. So let's talk about colorectal liver metastases. The concept of liver transplant for non-resectable colorectal liver metastases was reinvigorated in 2012 by the Norwegians, who conducted a small study, a sample size of about 21, that showed 60% 5-year survival among liver transplant recipients transplanted for non-resectable colorectal liver metastases. So the inclusion criteria for these patients for the SECA-1 study was the primary tumor had to have been resected. They had to have good performance status, so an ECOG of 0 to 1. They had to have a minimum of 6 weeks of chemotherapy and no evidence of extrahepatic disease. What they saw was high recurrence rates, so 90% recurrence, and with only a median time to recurrence of 6 months. The pulmonary recurrence was the most common site of disease, and a sizable proportion of these patients were still resectable at 27 and remained disease-free 27 months after that. So the high recurrent, the 5-year survival rates were excellent and reinvigorated interest in this indication for liver transplant. But the high recurrence rates inspired the follow-up SECA-2 study. Again, a small study with 15 patients But based on the information gleaned from the first study, the authors had more stringent inclusion criteria. So they insisted, in order for patients to be eligible, patients had to demonstrate at least a 10% response after chemotherapy. Time from diagnosis of the colorectal cancer to liver transplant had to exceed 1 year. And this was because a lot of recurrence rates were seen in patients who underwent liver transplant less than 1 year after initial diagnosis. They also restricted inclusion candidacy to patients with an Oslo score of 0 to 1. And these outcomes were also very impressive. So 83% 5-year survival, only 35% disease-free survival at 5 years, but 73% 4-year overall survival after recurrence. So signifying that the recurrences were less aggressive. And then they've subsequently published follow-up 10-year survival exceeding 25%. So, this work has inspired a number of prospective trials, some of which are listed here, currently evaluating liver transplant for colorectal liver metastases in both resectable and unresectable candidates, utilizing whole or partial liver transplants, also incorporating prognostic biomarkers, and one commonality is that most of these insist on long intervals from primary tumor resection to transplant and control of disease with adjuvant therapy. So, in studies that are looking at living donor liver transplant for this purpose tend to have more liberal inclusion criteria for some of the ethical reasons we talked about before. But at this stage, liver transplant for colorectal liver metastasis is largely investigational. I'll talk very quickly, since we're short on time, about liver transplant for neuroendocrine tumors. The NET Milan criteria dictates eligibility for liver transplant at this point in most parts of the world. So the primary tumor has to be drained by the portal system. Primary tumor has to be resected. The remove extrahepatic disease has to be cleared before liver transplant. Patients should demonstrate 6 months of disease stability before liver transplant, and metastases, hepatic metastases, should involve less than 50% of total liver volume. With that, 10-year survival has been shown to be quite good, approaching 90% versus only 22% in non-transplant patients. So I'll talk a little bit about this concept of organ supply. So when I talk about donor organs, you can think about them kind of like used cars. So they can run the spectrum from nearly brand new and near perfect to cars that won't run. And as I see it, the key barrier to more aggressive application of liver transplant for cancer indications is the limited supply of organs. And there are some exciting initiatives that we've seen in recent years to enhance organ supply and kind of reduce the barriers to undertaking more aggressive transplant for transplant oncology. I think this is going to shape things. So notably, the use of DCD donors, living donation, split liver transplant, and applications of technologies like machine perfusion, which is going to greatly enhance organ supply. So machine perfusion right now, there are devices that we basically procure a liver, we can put it on a pump, and there are two different types right now that are currently available: hypothermic oxygenated perfusion pumps and normothermic pumps. Both have been shown to reduce what we call early allograft dysfunction, so dysfunction of the liver early after liver transplant, and to reduce non-anastomotic biliary complications such as ischemic cholangiopathy, which are really devastating complications, and a complication that we've seen in up to 10% of DCD liver transplants. So these technologies hold the promise to allow us to use more marginal organs that we might not otherwise consider for transplant because of poor quality, particularly donors with livers with a lot of steatosis or livers from DCD donors that are suboptimal. So this is one application here at my institution. We're using hypothermic oxygenated machine perfusion. This is a liver from a 79-year-old donor, so a donor that is pushing the boundaries of what we tend to do, and was used for a complicated recipient, an elderly recipient with decompensated cirrhosis, significant portal hypertension, a challenging hepatectomy from extensive adhesions from prior surgeries. But the pump, putting this liver on the pump allows us to, take on more aggressive cases like this and use more marginal organs. And, this is just one example, but this patient went home on postoperative day 5, which is about as quickly as you can go home after a liver transplant. So I'll pause there for questions. I'm sorry we're running short on time, but thank you for the opportunity to speak.
Thank you so much. I have one question. In your experience, what is the most candidates for liver transplant after, if you not include cirrhotic patients, whom you perform liver transplantation due to oncological diagnosis mostly in your clinic?
I'm sorry, just so I understand the question. The question is if patients are not cirrhotic, what is the most common indication?
I mean, if we will not take the group of patients with cirrhosis, everybody understand that they need to perform transplantation. But in the second place, who get the indication for liver transplant in your clinic? I mean, cholangiocarcinoma or maybe neuroendocrine mets patients in your general practice, who it will be?
Yes, I think, still probably the majority of patients are going to be HCC patients, but without advanced cirrhosis. Am I still there? Okay. So, yeah, we in all honesty, we don't do a lot of cholangiocarcinoma and not much neuroendocrine either. So only a handful a year.
Rectal, sometimes.
And yes, we've done a handful of colorectal transplants as well, but still, it's still HCC. And
okay, thank you. We have one more question, please.
Do you ever use repeat procedure in your institution?
The question about the repeat transplant for the same patient, if you have tumor progression or metastasis in the transplant liver, how often you will perform secondary transplantation for this patient?
Yeah, almost never. Certainly, if there's any disease, extrahepatic disease, they're not going to be a candidate. And when patients recur, it's typically extrahepatic. So I can't think of a recent case in which we've had tumor recurrence within the liver.
Okay, thank you. We really appreciate your time and your level of expertise in this question. Hope to see you in Kyiv, maybe next time.
Thank you.
Thank you.
Yes, thank you so much. Good to see you.
Thank you. We're continuing to the next presentation. Pani Nataliya with a presentation about biliary tract systematic therapy from University of Wisconsin School of Medicine and Public Health, United States. Наталя, ви з нами?
Дуже приємно, добрий день. Дуже дякую за запрошення приймати участь у вашій конференції. Я хочу запитати, чи ви бачите нормально мій екран? Display settings, там що показує слайди, так?
Так, все добре.
Я медичний онколог. Я зараз працюю в університеті в Вісконсині. Я спеціалізуюся в системних терапіях of upper GI cancers, biliary tract cancer, гастрологічний онколог. І я сьогодні буду вам розказувати про хімотерапію а також targeted therapies для cholangiocarcinoma. Я буду говорити по-англійськи, але я зможу на питання відповісти в кінці по-українськи, якщо так легше. This is the outline of my talk. I'll talk about generally biliary tract cancers, then we'll talk about early stage biliary tract cancers approaches, and then we'll switch to advanced biliary tract cancers and really spending a portion of my talk talking about targeted therapies. So first of all, biliary tract cancers is a heterogeneous group of cancers, and that's very important to keep in mind when we look at the data about these diseases and when we try to develop new treatments going forward. Patients with these cancers have poor prognosis. They represent a small percentage of GI cancers right now, but the incidence is increasing, and a 5-year survival rate of less than 10%. Resection is the only curative modality, and I think this talk is timely after just a prior talk about liver transplantation, because we really are trying really hard to cure these patients, but without resection, cure is not possible. And 1 in 5 patients at the time of diagnosis are resectable. There's a huge variability in terms of the incidence of the cholangiocarcinomas across the world. And because of that, the biology of these tumors also varies from different portions, geographical regions of the world, because the risk factors are different, and biologically, these are different entities depending on where in the world they're diagnosed. So how do we approach early stage biliary tract cancers? Well, as I've said earlier, resection is critical for cure, but adjuvant therapy is now standard treatment. And the reason we talk about adjuvant therapy for these patients is because the recurrence rates are very high after complete resection, and 5-year overall survival is less than 50%, even after resection with curative intent. The poor prognostic factors after resection include those patients who have positive lymph nodes at the time of resection, resection with positive margins or R1 resections, and vascular invasion. There are no proven neoadjuvant therapies right now, and so the only therapies that we typically give is after resection. In the United States, 6 months of adjuvant capecitabine is now standard adjuvant therapy, and I will show some of the data to support this approach, but this is our standard here. And the historical perspective is that up until 2017, we really had no randomized trials to tell us, should we give any chemo or not? We had a sense that we probably should because the recurrence were so high, but there was no data to support this. The meta-analysis that looked at adjuvant therapies it looked at 6,700 patients and looked at studies over the span of 50 years, showed that yes, adjuvant therapies improve survival, chemo seems to be better, and chemotherapy and radiation seems to be better than radiation alone. But we now know that radiation may actually help some patients with R1 resection. And so there were these 3 adjuvant trials that resulted around the same time that looked at different chemotherapies after resection. One of them, BCAT, was a trial that involved primarily only distal cholangio and perihilar cholangio. And this was a negative study. It looked at adjuvant gemcitabine. You can see overlapping overall survival curve, negative study. Another study that came out at the same time was a protégé study from Europe that looked at the combination of gemcitabine and oxaliplatin after resection of all biliary tract cancers. Again, it was a negative study. The curves, PFS and overall survival curves were overlapping. And so that brings me to the only positive study in adjuvant setting, which was a BILCAP study that enrolled 447 patients, and it enrolled all biliary tract cancers, intrahepatic, hilar, gallbladder, and lower bile duct cancers. The issue with this study was that it took 11 years to complete. So that just tells us how challenging it is to study systemic therapy in these patients, rare disease, difficult patient population, heterogeneous patient population. But in this study, patients after resection, curative intent resection, were randomized to 8 cycles of 6 months to capecitabine versus surveillance. The primary endpoint was overall survival in intent to treat patients, so all patients that were enrolled in the study. And so this study showed that recurrence-free survival was definitely improved with 6 months of capecitabine with both in intent to treat analysis and per protocol analysis of the patient that actually received treatment on study. And the overall survival, although it was numerically longer in intent to treat patients, it actually did not reach statistical significance. And so there's a lot of discussion about what does this mean, because there you have an inconsistency between per protocol and intent to treat analysis. But the issue is that this is the best study we have right now. This does prolong, this does delay recurrences, and numerically, and in those patients who actually enrolled in treatment, does improve overall survival. And so I think this is a valid study to follow, and this is something that we have incorporated into our practice. But some things to keep in mind is that because it took such a long time to complete, the statistical plan had to be changed during the protocol. The control arm did better than predicted, probably with better systemic therapies and better surgical techniques. And then there still remains a question, who are the patients that truly benefit? Is there actually a subgroup of patients that benefit? Regardless, in the United States, based on the BILCAP trial, ASCO and NCCN endorses this as a standard adjuvant therapy for patients with resected cholangiocarcinoma. So all of the patients here receive 6 months of capecitabine after resection. One exception may be extrahepatic cholangiocarcinoma on gallbladder cancer, especially those that have R1 resection of positive lymph node, where there is some data that radiation may play a role. And for these patients, we would consider combination of chemotherapy and chemoradiation, and this is not supported by phase 3 study, but this is based on cooperative group SWOG S0809 study, which is a single arm phase 2 study that showed that there's patients with these high-risk tumors, extrahepatic and gallbladder, that probably benefit from radiation. So I will switch gears now and talk about systemic treatments for advanced biliary tract cancers, which is where all of the advances were done most recently. First-line treatments now include immunotherapy. For many years, going back to 2010, the only first-line treatment that we've had for the treatment of these diseases with combination of gemcitabine and cisplatin. And this was based on a seminal phase 3 trial that was published in New England Journal of Medicine in 2010 that compared gemcitabine and cisplatin to gemcitabine. The overall survival was improved, but it is pretty poor still, 11.7 months in first-line treatment, starting from first-line treatment of this disease. So in the past couple of years, we have had a number of studies that looked at the addition of immune checkpoint inhibitors. TOPAZ-1 was the first such study, and this is really the first study after ABC02 that was the first phase 3 positive study in this patient population. This study enrolled patients with advanced biliary tract cancers that had no prior treatment. Patients were enrolled from around the world, and they were randomized to either standard of care gemcitabine cisplatin, 8 cycles, so 6 months, or gemcitabine cisplatin and durvalumab for 6 months, followed by durvalumab maintenance. The primary endpoint was overall survival. The study was positive. Overall survival was improved with addition of durvalumab. But if you look at these numbers, 12.9 months versus 11.3 months, I personally found them disappointing after I actually saw the results after the press release. The improvements are very marginal. When you look at the longer time follow-up, this was presented at ESMO 2022, so not really published yet. When you look at the longer follow-up, the patients who actually survive up to 1 to 2 years, there's the overall survival rate at 24 months is 24%. So if you pick the right patients who could benefit, we do see prolonged benefit from immunotherapy, but the median survival is quite, the difference median survival is quite limited, and the curves are very much overlapping during the first 6 months of treatment. And so it begs the question, who are the patients who are really benefiting? In the forest plot from the study, when they looked at pre-specified subgroup analysis, you can see, so this is a forest plot hazard ratio of 1. If the lines cross hazard ratio 1, I'm sure you know how to read these plots. But if it crosses 1, it means there's no statistical difference. And what I wanted to point out that when you look at non-Asian patients, you see that the hazard ratio comfortably crosses 1. When you look at the rest of the world versus Asia, the hazard ratio comfortably crosses 1. And so the question is, which patients truly benefit? The other study, once we're talking about immunotherapy to bring up, which is a very similar study. This study has not led to approval yet, but involved the same patient population. This is a Keynote 966. This is the study was presented at AACR in the spring meeting of 2023, and that was a concurrent publication now. But this study looked at the addition of pembrolizumab. So this is anti-PD-1 antibody. Durvalumab is anti-PD-L1 antibody in combination of gemcitabine and cisplatin. Similar patient population. The only difference between the study was that chemotherapy was not stopped after 6 months, and it was continued in combination of pembrolizumab while it was stopped in the prior study. This was a positive study as well. Overall survival was improved with pembrolizumab addition. However, we are also seeing modest overall survival benefits, 12.7 versus 10.9 months. And again, it begs the question, who are the patients who are benefiting? Here we've seen different results. North Asia, geographic region that's from North Asia actually does better than the Asian patients. So I think we need to, although we are seeing a glimpse of activity, a glimpse of hope that immunotherapy has activity in these tumors, I think figuring out who is truly benefiting is going to be key. Regardless, even though the signal was small, based on a phase 3 TOPAZ trial in the United States, FDA approved durvalumab in combination with gemcitabine and cisplatin for patients with advanced untreated biliary tract cancers. And per NCCN guidelines, which is our national guidelines that establish the standards for oncologic treatments, durvalumab is now included as a category 1 recommendation as part of the first-line regimen. Pembrolizumab is not included yet. The data is very recent, so it is not approved for the treatment. I'm going to switch gears now and talk about late lines. So what do we do after patients progressed on first-line chemotherapy? And up until recently, the treatment options were very sparse and very limited. The only chemotherapy that is approved and that is supported by phase 3 data is FOLFOX, just combination of 5-FU and oxaliplatin. And this is based on a phase 3 ABC06 trial that compared FOLFOX to active symptom control, so best supportive care. The improvement in overall survival is marginal, 6.2 versus 5.3 months, less than 1 month. None of us are excited about using FOLFOX in second-line setting. We use it just because up until recently, there were no other options, and most patients still consider, for most patients, this is still really the standard treatment. However, limited activity in this disease. So let's talk about targeted therapies for biliary tract cancers, because this is really where most of the advancements in the treatment of biliary tract cancers have been made. And this has really changed, really truly changed the course and the treatments of a number of our patients. So first of all, going back to where I started, biliary tract cancers is a heterogeneous group of diseases, and it's really one name for many different diseases anatomically, but also molecularly. You don't have to read the small print, which lists the most common mutations for gallbladder cancer, extracellular carcinoma, or intrahepatic cholangiocarcinoma. You don't have to read all the small print, but you can see that the group of mutations between these 3 entities is different. And characterizing these mutations, it is not just a pure academic exercise. We are actually now finding targets for which we have drugs. And I want to give you some summary of some of the recent advancements really in these targeted agents that are being developed. The first one I'll talk about is IDH1. IDH1 mutations are present in about 20% of intrahepatic cholangiocarcinomas. This is the main biliary tract cancer where we are seeing these mutations. And IDH1, when it's mutated, leads to accumulation of 2-hydroxyglutarate. I'm not going to go into the detail of this pathway, but when this molecule, when 2-hydroxyglutarate accumulates, it results in changes in gene expression, and somehow that predisposes cells to developing cancer. The exact mechanism is not known. We see IDH alterations in many different diseases, including brain tumors and hematologic malignancies. And so there was a drug that was already approved, ivosidenib, for AML. And so the phase 3 trial, Clarity trial, looked at the activity of ivosidenib in IDH1 mutant cholangiocarcinoma after progression of standard therapy. The primary endpoint of this trial was progression-free survival. It did not look at overall survival as a primary endpoint because it was a placebo-controlled trial in which crossover to the drug was allowed. And PFS, progression-free survival, was significantly improved with ivosidenib. In addition, this drug has very minimal side effects. And so now FDA has approved ivosidenib for the treatment of for IDH mutant biliary tract cancer. The drug does not result in any significant responses. So when we use these patients, and our patients, and I have treated a number of patients on this study, which was open at my institution, the tumor does not downstage, the tumor doesn't shrink, but patients have minimal side effects. And so this is a very reasonable option to use in patients who have IDH mutant cholangiocarcinoma. Let's talk about the next target, FGFR2. There has been a lot of activity with FGFR2. FGFR, or fibroblast growth factor receptor, it's a receptor tyrosine kinase. In normal cells, it regulates metabolism, endocrine functions, it participates in wound repair, but when it's deregulated, it can lead to oncogenesis, tumor progression, and treatment resistance. And there's many different ways this receptor tyrosine kinase can be deregulated in tumor cells. One of them is it can have activating mutations so that the receptor tyrosine kinase is constantly on and signals to its downstream cascades. Another one is that part of the gene can be fused to another gene, so we have a fusion, and because of that fusion, the receptors are constantly dimerized, and because of that dimerization, they're constantly on, again, leading to constitutive activation of the signaling. Or you can have a lot of this receptor, and it's overexpressed, and this is not really relevant to cholangiocarcinoma, the expression we see more in upper GI cancers. And so we have now two FGFR2 inhibitors that are approved for the treatment of FGFR2 fusion positive cholangiocarcinoma, futibatinib and pemigatinib. Futibatinib is an irreversible inhibitor, and so covalent inhibitor, pemigatinib is an irreversible inhibitor. And there are many more in developments. And it's incredible to see these waterfall plots. I'm sure many of you know what these plots are, but on these plots, each individual line represents an individual patient. And going down means that the tumor is decreasing in size. The minus 30% reduction in a tumor or more is considered partial response. But even those tumors that have not received partial response, a lot of them are still decreasing in size. And so it's rare to see in GI oncology and especially in biliary tract cancers, such impressive waterfall plots where the majority of patients' tumors are decreasing in size. And so overall response rate with these two drugs was 43% and 35%. And we are seeing unprecedented overall survivals. 21.7 months and 21.1 months. This is in second and third line setting. You may remember I shown you earlier, FOLFOX in second line, when we just use chemotherapy without biomarker selection, overall survival was about 6 months. Here we are seeing potentially after FOLFOX even overall survival of 21 months. These therapies really have markedly changed how some of the patients, how long some of the patients live on treatment. The typical side effects that we see are hyperphosphatemia, which is an on-target effect of these FGFR inhibitors. As medical oncologists, we now know how to deal with them. We use phosphate binders, drugs like Ranvella and Renagel that patients with end-stage renal disease are frequently on, not a big deal. And also we see some diarrhea, again, something we can manage. This is a patient of mine. I just want to show you, I think it's interesting to look at cases. This is a patient of mine who was initially treated on a pemigatinib trial. We had an Insights pemigatinib trial open here, and I had a number of patients on. So this was a 63-year-old male who came in with a large cholangiocarcinoma diagnosed back in 2017. He had first-line chemotherapy, gemcitabine, cisplatin, progressed, NGS, next-generation sequencing testing demonstrated the fusion, and he was treated with pemigatinib and had an incredible response. The response was pretty long-lasting. Patients ultimately developed resistance, but this is just to show you like the kind of responses we see in clinic. One thing that I want to point out to also medical oncologists in the audience is some of the cutaneous toxicities that we are seeing with these drugs, which are significant. They're not, they develop late. This is again the patient of mine that I treated with these inhibitors. They develop 6 to 8 months after treatment, but they can be pretty significant. It can affect quality of life. I have patients who lost all their nails, a lot of skin redness, irritation. And so holding the drug and reducing the dose can be helpful, but this is something that can be quite significant. But even when we see these amazing responses, and these are the other couple patients that I treated on trials in the past, even when we see responses, resistance is always inevitable. These patients can develop secondary mutations. This is, I tend to repeat testing for my patients with repeat NGS testing or liquid biopsy, and this is the mutation that I've seen. And this was just also been published in the publication in the Journal of Medicine. We were also part of the site for this futibatinib trial. And when they looked at the mutations, they do see multiple different mutations that predispose to resistance to these drugs, which is why it was so exciting to see the study from Relay at ASCO 2023, where I met some of the colleagues that are present today in the conference, that looked at the activity of the very selective FGFR2 inhibitor in FGFR2 fusion mutant cholangiocarcinoma. And what this study has shown, and some of that information has already been presented at ESMO before, you're seeing amazing responses. The dose is more than 70. This is going to be the dose going forward. You're seeing amazing responses, 73%. Basically, nobody progressed on this drug, which is amazing in an FGFR inhibitor naive patients. But we're also seeing that we're seeing responses now in FGFR inhibitor pre-treated patients, which is really what there's going to be a big need now that we have 2 FGFR inhibitors approved for therapies. So let me switch gears and talk briefly about HER2 or B2, because there's a lot of drugs that are being developed for these tumors as well. And HER2 expression or amplification is quite common in gallbladder carcinoma. It's common, it's about 16%. The cancer itself is very rare, but when you can find it in almost a fifth of patients, I think it's worth looking. And so last year, this is ASCO 2022, there was study with trastuzumab deruxtecan in these patients. Trastuzumab deruxtecan is an antibody drug conjugate. So it's basically part of the molecule is an antibody. It binds the same epitope that trastuzumab binds. And another part of the antibody is a chemo, so it brings chemo. Chemo is similar mechanism of action to irinotecan. And the study was done in Japan, and they looked at the activity of this drug in HER2 positive tumors. Again, you see a response rate of 36%, something that you don't usually achieve with chemotherapy. And last year, there was this interesting comparison of other regimen in the setting. You can see overall response rate from FOLFOX in late line was 5%. Here we're seeing trastuzumab deruxtecan 36.4%. This year at ASCO, there were 2 oral presentations about the treatment of HER2 positive biliary tract cancers. One of them looking at tucatinib plus trastuzumab, tucatinib small molecule inhibitor of HER2. Trastuzumab is anti-HER2 antibody. Biliary tract cancers were part of the basket cohort. And again, we are seeing beautiful waterfall plots, overall response rate of 47%, and overall survival 15 months. Again, much longer than what we've seen with standard chemotherapy. And this is after a median of 2 lines of therapy, and some patients had up to 4 prior lines of therapy. Another study that was presented with a study with zanidatamab, which is a bispecific HER2-directed antibody. So this antibody binds to the same epitope as trastuzumab, but also binds to the other epitope, that same epitope as pertuzumab, so kind of a hybrid antibody. And this molecule has shown activity against HER2-positive tumors across different disease types. And now with this molecule, we're also seeing impressive responses. Overall response rate 41%, and overall survival very similar actually to trastuzumab and tucatinib of 15.5 months. So even though there are no truly approved agents for HER2 positive disease, I think it is worth testing. We have agents approved for other diseases that go after HER2, and we can. The testing is easy. It's usually we can test IHC, although next generation sequencing is possible as well. But the drugs appear to be quite active. And the last one that I want to talk about very briefly is BRAF. So BRAF alterations are rare. V600E BRAF alteration are present in a small percentage of patients, which is why it's really hard to study specifically to have a study specifically for biliary tract cancers with BRAF alterations, but these patients were included in basket studies. And again, we've seen beautiful response that the targeted agents have response rate of 36% with overall survival of 12 months. And most patients had 2 or more prior lines of therapy. So which means they've had GEM-CIS, probably FOLFOX, and they still, after that, had significant clinical benefit. And this is a patient of mine, again, a case that has V600E mutant cholangiocarcinoma, 52-year-old female, was diagnosed with this very large liver mass. This is a picture from January 2022. Started her on gemcitabine and cisplatin. She didn't progress. Her tumor did not progress, but there was no responses. We treated it because she was feeling okay, and I knew she had a mutation, but I figured there's no reason to stop something that her tumor is not working on. So she's completed 6 months of treatment, but subsequently I switched to targeted therapies. These are not approved drug. These are part of the trial that we have open here, and she's had a pretty nice response, a very nice response. Disease still remains unresectable, but she was able to actually get consolidated radiation to her tumor and has been off any treatment now for 4 months with stable disease and normal tumor markers. So in summary, I've covered a lot of different information about biliary tract cancers, which is really, biliary tract cancers, I think, is really the poster child for precision oncology among GI cancers. But when we think about personalized approach to patients with biliary tract cancers, I think there's a few things that are very important to consider. First of all, age, comorbidities, how is the patient feeling? Is the patient really a candidate for systemic therapies? We also need to think about, is the tumor resectable? What is the tumor burden? Where's the location of the tumor? All of this that our surgical colleagues can really help us with. But as medical oncologists, the molecular features of the tumors are becoming extremely important. All our patients undergo molecular testing at the time of diagnosis of advanced disease, where we look for mutations, fusions. All of our patients undergo immunohistochemical biomarker testing for HER2 and for mismatch repair protein expression to look at microsatellite status. We didn't talk about this today. It's quite rare in biliary tract cancers, but this is our automatically all advanced GI cancers are tested for mismatch repair protein to see whether there is a potential microsatellite instability. And then taking all of that into consideration, it's really a discussion with a patient as to, what are their goals of treatment, what implications our treatments will have on their quality of life, and what toxicity profiles different regimens are. As you can see, we have multiple different HER2 regimens. How do you pick the best one? And I think it's going to be not just the activity, but also frequency of drug administration and toxicity profiles. So in summary, biliary tract cancers is first of all, group of diverse diseases. Anatomic and molecular definitions are extremely important for therapy development, and especially since most novel oncologic therapies are non-cytotoxic agents. They're either immunotherapy or targeted therapy. And so biomarker characterization is going to be and is essential for optimal therapy selection. I think future treatments will look at the combination, targeted therapies plus immunotherapy, combination targeted therapies, combination with radiation. And so it's going to be very important for us to collect some of these samples to look at biomarkers, and the ongoing translational research, how to overcome these resistance is going to be critical for novel drug development. So I would like to thank you for your attention. I would be happy to take questions. І слава Україні!
Аля, дуже дякуємо вам за чудову презентацію. На жаль, певний песимізм залишається поки що по лікуванню, особливо метастатичного раку білярної системи. І без якихось брейктру за останні декади, це точно. Тому чи є у вас якийсь досвід, що нам якимось чином ctDNA може в цьому допомогти, чи це також все зараз поки що clinical trial? Є якісь, може, у вас? Так.
So there's two ways to use ctDNA. We use ctDNA for testing to find what mutations are present, which is what we do use in our practice. So we use the company called Guardant 360. That's the one that I use the most. And this is a quick way to find out whether there's any mutations or fusions in the tumor. And we do use that to help us find patients who can be candidates for therapies. And sometimes it's faster and potentially cheaper to get those results. The other way is to use ctDNA, which is the way we use ctDNA in colon cancers, to look for minimal residual disease. After resection, you can see, is there still ctDNA in the blood? And are these patients, who are the patients who are at a higher risk for recurrences? And that really still is really under investigation, because we don't have any great therapies. You know, even if it's positive, you'll still give capecitabine. So there's really it's not going to change what we do in adjuvant setting.
Ще раз вам дуже дякую за те, що були з нами, за чудову презентацію. І бажаємо всього найкращого. Ми продовжуємо далі. І у нас фінальна презентація. Я ще раз з радістю запрошую пана Віталія. Ми трошки зсунулись по часу по хірургії, тому перенесли доповідь на кінець дня сьогоднішнього.
Дякую. I think it's only appropriate that we are finishing up at the rectum, because that's where things end. And it's also, as we all know, the most important part of a GI tract. That everything else was just a warm-up. And my talk today is going to be on watch and wait. And it's structured a little bit differently, because what I wanted to do is talk about more specific and practical aspects on watch and wait. Dr. Bordeianou already actually very nicely outlined in her talk the studies that led us to consider watch and wait. So I wanted to kind of bring the actual kind of protocols and how we do things. All right. So I have no disclosures. And my goal today is to review the current indication, review how to wait and how to watch, and understand the ongoing issues with non-operative management. Accidental wait and watch, watch and wait, has been done for a very, very long time. It's been done for decades, as a matter of fact. But there's been, whatever it's between the patients who refuse surgery, were lost to follow up, or were considered to be too sick. And then some of them did actually just fine without resection. And then there are also people who we kind of knew that the complete response happens after the surgery, and we'll take out a specimen and find nothing. But the concerns remain, the concerns about recurrence and overall worse outcome. And the big question always was, let's say it looks like we can watch these folks, and then we do, and then they recur. Can we give them the same outcome as it would have been if we took them to surgery right away? However, that needed to be balanced with all the potential issues associated with surgery. Anything from need for permanent stoma to just the surgical complications, anything from infections and bleeding and leaks, and as well as functional issues. Lars is missing an S in the slide here. But eventually, what started as kind of observation and curiosity, initially through hard work of Dr. Abergama, and eventually extended throughout the world, we now came to the intentional watch and wait. And after a lot of studies, a lot of observations, a lot of analyses, and oftentimes a lot of arguments, these are the reasons why we can actually do this. So there is a good correlation between the people who have a complete clinical response and complete pathologic response. Overall, patients with complete response will have only 25% of recurrence. Now, most of these recurrences will happen within 2 years. Another very important thing that allows us to do this intentionally is most of the recurrences will be within rectal wall. And more than 90% of these recurrences are going to be amendable to primary resection when recurrence is noted. And there is the same rate of metastatic disease in these patients. So that kind of lays the foundation for why we can actually do this. Now, so let's say you really want to offer it to your patient, and how are you going to do that? Or you want to make it part of your practice if you have not yet. There are practically a couple of things that need to be done. So these folks really need to have a complete neoadjuvant treatment. Even though, as Dr. Bordeianou discussed, different protocols showed really kind of different response, and sometimes we see a longer, shorter course. But the reality is they all need to have all their treatments up front. You need to have a complete clinical response, and we'll come back to that, what it actually means. You have to have a willing patient and a reliable patient who understand the risk. To give you an idea, we actually consent patient. We get a permission from a patient, signed permission, to do watch and wait, just as we do if we take them to surgery. Overall recommendation is that it's not just your decision in a patient, you have to get the rest of your team on board. And this is a multidisciplinary disease, so for decision in our institution to proceed with this as an option is actually after we discuss at our MDT. The patient needs to have an ability to follow, okay? They have to be able to show up for their treatments. They have to be able to make it back to you. They have to be able to do the tests that they need to do. Now, the next thing you're going to do is assess the response. So first one is going to be an exam. And to have a complete clinical response, there needs to be no evidence of luminal disease, because remember, most of the kind of recurrences or remaining disease is going to be within the wall. And that means on a direct rectal examination, no or minimal changes to palpation. You should not be feeling any masses or anything like that. It is much easier for distal cancers. It's obviously much harder once you start going mid to rectal cancer. Probably one of the more important part in that is also endoscopy. And flexible endoscopy is really preferred to rigid proctosigmoidoscopy because you can see things better, you can zoom, you can get a better pattern around it. And on that, you should see if a completely normal mucosa or it's just a little bit of whitening with telangiectasia. That is what you're actually looking for. There can be a little bit of scarring, but it needs to be quite minimal, okay? You don't need to take the biopsy. That's really not necessary because in this setting, the negative biopsy does not rule out that there is no persistent disease. And you can actually generate some more scar. Now, as importantly, these patients need radiologic assessments, most important of which is practically what we are looking for is no radiologic evidence of a disease, okay? And the main thing we're looking for is an MRI, and a well-done MRI, which you compare to before, and remember the lecture from earlier, kind of a standard workup, but kind of needs to be done, and to after. And what you're looking for is low signal intensity on the two weighted images, only dark signal. That's ideally what we want to see. We want to see the absence of diffusion restriction. There are some criteria from radiological societies, and if your radiologist is not that familiar, you can discuss with them exactly what you're looking for. The tumor regression grade of 1, absence of suspicious lymph nodes, and of course you want to see no evidence of metastatic disease when you restage this patient after you've done a TNT. So, in our institution, if a patient has what looks like a complete clinical response, and at that point they're usually going to be seeing me as well as one of our medical oncologists. We're going to have an MDT discussion with a patient. offering them as one of the options. It's not the option, it's one of the options. They have to have a willingness and ability to do this, sign a consent, sign a permission, and then we're going to follow. This is slightly outdated as far as a date, but overall, the only difference what you will see compared to a regular follow-up, so we will see them for the first 2 years. We're going to do an exam, CEA, and endoscopy. I'm going to do that in clinic every 3 to 4 months. Now, the NCCN 2023 says that you can do MRI every 6 months, and it's perfectly fine. We decided that our tumor boards, but we are kind of anxious, and as long as insurance permits us and covers it, we're not asking patient to cover this. For us, it's insurance. As long as insurance permits us, and they oftentimes do, we will actually do an MRI, at least in the beginning, at every 3 to 4 months, and then start spreading things out, and then CT scan at 6 months. And then once we get to a year 3 to 5, we, since most of our recurrences would happen by that time, we start relaxing things a little bit. Now, it's not uncommon to see what's called a near complete response. And what does that mean? So you see a patient and there is a minimal kind of questionable irregularity. It's not bad, it's not the tumor kind of gone, but maybe it's not just as smooth of a surface as you think it should be. There is no visible mass on endoscopy, but there is an ulcer, okay? And there is no kind of nothing else. It's kind of, it's not horrible, but it's not bad. On the MRI, it's near complete response. There is some T2 signal. It's, the tumor response grade of 2. It's not 1. So it's kind of almost there, but it's not quite there. So what we do, we reassess that patient in 6 to 12 weeks. We will give them a chance to see, because we know the number of people will still convert to a full response. So putting it in our way, so you have a patient with neoadjuvant therapy. This is from ASCRS textbook from Dr. Garcia Goulart, who done a lot of this work early on. At 8 weeks, we're going to assess the responses we discuss. If I have a clear, complete response, we're going to put them on watch and wait protocol right away. If I have an incomplete response, meaning the mass is still there, the MRI is not clear, we see the lymph nodes, we're going to proceed with a TME. And if it's a near complete response, we're going to reassess and actually do exactly the same set in about 6 to 8 weeks, and the patients are going to practically split. If I still see in kind of near complete response, but it's not complete, my general recommendation for a patient is to proceed with TME, because more often than not, you're going to find something. And if I have a complete response, which you oftentimes will, then we will watch them. Now, there are some other considerations, because it's not uncommon for the therapy that we give folks, especially radiation, to have a great effect on the tumor, but we still need to consider surgery. So strictures being one of them, okay? So the patient, this is a patient of mine who had a great response, right? She has a complete clinical and pathologic response, as a matter of fact. However, she actually was symptomatic from a very tight stricture, and we could not follow because we just couldn't get through a stricture with anything that we needed to do, okay? Symptoms, as I mentioned. And then on imaging, one of the things which we need to consider is that, and that's kind of a basis for this near complete response. It's not uncommon to see very good endoscopic response, but incomplete response on MRI. Close, but not quite. A little bit of that T2 still present. So in some cases, when everything is completely great, we will just, and it's not common to overcall it and there is a lag radiologically, we will just wait. Sometimes, if I'm very worried, I'll send them for endoscopic ultrasound. I haven't found it to be that useful, but sometimes it makes me feel better and my oncologists feel better, and there is something to be said for that. There is, PET MRI, especially if one was done before. We're still playing with that technology and trying to figure out what the role of it is. But this actually kind of finding some of these is probably one of them. Now, other things are going to be macrosatellite unstable cancers. Because now, after there's a New England Journal paper showing some of these folks having a complete responses to immunotherapy. This is also one of my patients, and you see coming in with this big, ugly tumor, huge lymph nodes, positive mesorectal margin, like 35-year-old, not fun, completely melted away, right? Now we're going on, I think, just over a year without any evidence of disease. However, some of this is still being worked out. A lot of it, as Dr. Kalyan pointed out, we still don't quite know. So we're still watching this, folks, very closely, because if you look at that New England Journal paper, even though we see these tumors not all that infrequently, only proportion of those patients will actually qualify for that New England Journal paper, okay? Now, the other things that we're still debating, very nicely outlined by Dr. Bordeianou, is the whole long versus short course and what does it actually mean. And that goes back to what are your patient goals? What are your goals? What is that what you're trying to achieve? Okay? And I'm going to stop here and see if there are any questions. Please.
Okay, thank you very much for the topic. And the question is, in those cases when it's, as you said, that you have some doubts, it could be complete or no complete response, why do not to perform full layer local resection?
Yeah.
And check the margins and all the things.
Right, that's a great question, and it's so there is some data actually from Dr. Garcia Goulart in his trials when he did total neoadjuvant on T2 tumors and then just watched them and did the resection. But the thing is, we don't have a huge amount of data to show that. After radiation in that study, there was a wound complication rate of about 50%. If you find it negative, it's not a guarantee that they actually are negative, because we know that the tumor response is not uniform. And it's actually going to make it very difficult for you to both follow afterwards, because let's say you find nothing, but now there is going to be a very funky scar and you don't know what to do with it. That's kind of number one. And I also got burned in a couple of patients when I kind of gave in and I resected it, and I did exactly that to prove to a patient that there is something or not, and I had to convert later to TME, and it was not fun. Essentially, the scarring was really horrible in combination with everything, and I ended up getting into things I really did not want to be getting into. So
you do not recommend this?
I do not. No.
Okay, thank you. Yes.
I just want to make a point. What Dr. Poylin is referring to is advanced rectal cancers that you would normally pre-treat with TNT. At least that's what we're doing in the United States. So it's a T3 and 1 complete pathological response, and that's why a local excision doesn't make sense, because you're still not clearing the mesorectum, and the recurrence could be in the mesorectum. And monitoring of the rectal wall is easier than having to monitor the mesorectum as you would when you did a local excision. It's different from what you might be reading from the Habergama group from Brazil. And there are a couple of other studies along this vein where they're taking every low rectal cancer, regardless of the stage. If it's not amenable to a local excision, they may offer their patients chemotherapy and radiation in the TNT protocol, even for a T2, an anterior T2 rectal cancer. And in that patient, if they see a complete pathological response that's incomplete, there is some data from that group about doing a local excision in that very specific cohort. But we don't see a lot of these patients in the United States because we would not offer them TNT.
So thank you. And that's a great point about the local advance. So we have more and more patients coming into us with actually that, like T2 and 0 sitting right on the sphincter. And the standard is still to proceed with, in most of these folks are going to be abdominal perineal resection or hand-sewn if you can do that. However, some of these folks are coming in very specifically saying, I don't want to have surgery. And if they refuse surgery, we will offer them a TNT. And if they do respond, we will follow them. Again, this is much more experimental. This is not an NCCN guidelines. Sometimes I'll take a biopsy, but again, just as in that trial from MSK, the wound complication rates are pretty high. Doesn't necessarily guarantee things, but yeah, we see that too. The folks who just refuse, and then we'll just follow their lead.
Do we have any question from the chat? We previously had some question during the surgery, and your personal point of view of this term like partial TME.
Yeah.
What do you think about this?
You know, I think
It's appropriate for
yeah, of course.
some cases.
So I think some of it is really depends on the location of a tumor. For upper rectal tumor, the one that we are debating, whatever it's actually sigmoid dipping into the rectum, or maybe it's upper rectum going in without anything else, without any kind of negative features, I think it's fine to do a partial TME and not take it all the way down. But anything that's, you know, really I see lymph nodes within TME or confined within mesorectal fascia, I'm going to take all the way down.
How you check the level?
I'm sorry?
How you check the level of partial TME, for example? You start
Then I
to
go.
check this.
Then I go for at least 5 centimeters, as Dr.
Below
Liliana
the
put.
tumor.
Below the tumor, and I go. So I have a flexible.
If you have any signs of positive lymph nodes on MRI.
Yeah. So this is the tumor. This is the tumor that's, again, we kind of go and saying like, well, rectus sigmoid kind of right on top, maybe nothing. You know, let's say T2. I see no lymph nodes. They got nothing. And again, I have a flexible sigmoidoscope in the operating room, and I'm going to be looking. I'm going to be seeing, like, make sure that I really below where I'm going to go. So I go very carefully, but we do, me and my partners, we do a partial TME in some of these folks.
5, 6 below.
Yeah.
Okay.
Yeah.
Добре, якщо нема питань, то ми будемо завершувати перший день.
Дякую.
Thank you so much for our colleagues who joined to us.